ಇದನ್ನ ಬೇಡಲ್ಲ ಅದು ಬೇಕು. ಹಾಂ ಆಯ್ತು ಸರ್ ಬಂದಿಲ್ರಿ. ಕಾಲ್ ಮಾಡಿ ಸರ್ ಬಂದಿಲ್ರಿ. ಮತ್ತೆ ವಿಡಿಯೋ ಮೈಕ್ ಆನ್ ಮಾಡ್ಬಾರ್ದು. ಲಾಸ್ಟ್ ವಿಡಿಯೋ ಅಜಿತ್ ಕುಮಾರ್ ಮೈಕ್ ಆನ್ ಇದ್ರೆ ಆಗ್ಬೇಕು.
ओम धन्वंतराय नमः। ध्यान मूलम गुरु मूर्ति, पूजा मूलम गुरु पादम, मंत्र मूलम गुरु वाक्यम, मोक्ष मूलम गुरु कृपा. The root of meditation is the Guru's paw. The root of worship, the Guru's feet. The root of mantra, the Guru's word. The root of freedom, the Guru's grace. With the blessings of Guru, let us begin with another journey of webinar. Good afternoon, one and all. Myself, Dr. Sachin Javli, Department of Agat Tantra, Gramin Ayurvedic Medical College, Tirtha, welcomes you all for 4th National Webinar on Jnana Shalaka 2020. On behalf of the management, principal, teaching staff, non-teaching staff, hospital staff, students of SPVs, JV Wonders, Gramin Ayurvedic Medical College, Tirtha, Bagalkot, District, Karnataka, India. सर्वेषां स्वस्तिर्भवतु, सर्वेषां शान्तिर्भवतु, सर्वेषां पूर्णं भवतु, सर्वेषां मङ्गलं भवतु. May all be blessed with prosperity, may all be blessed with peace, may all be blessed with perfection, may all be blessed with bliss. A day without prayer is a day without blessing, and a life without prayer is a life without power. To get the blessings and power, let us start this inauguration function with a prayer. So I would like to call our students for the prayer.
ओम नमामि धन्वंतरी आदिदेवो सुरासुरवन्दिते पादपद्मं लोके जरारुगमृत्युनाशनं दातारधीशं विविध औषधीनां धन्वन्तरि रमानाथं सर्वरोगनिवारकम् आयुर्वेदप्रवर्तनं वन्दे वियुषदायकम् सर्वे जना सुखिनो भवन्तु सर्वे सन्तु निरामय सर्वे भद्राणि पश्यन्तु मा कश्चित् दुर्भाग् भवेत् ॐ शान्ति शान्ति शान्तिः।
Thank you all for the prayer. संतोषः परमो लाभः सत्संगः परमागतिः विचारः परमं ज्ञानं शमं हि परमं सुखम्. To get the knowledge from the satsanga, now I would like to request Dr. Shiv Prasad Hosmani sir for the welcome speech.
Good afternoon now. Myself, Dr. Shiv Prasad Hosmani, Department of Rashastra, Gramin Ayurvedic Medical College, Teta. It's my immense pleasure to welcome all of you for the inauguration of 4th National Webinar on Jnana Shalaka 2020. On behalf of management, principal, teaching staff, non-teaching staff, hospital staff, and students of Gramin Ayurvedic Medical College, Teta. It is my honor to welcome our today's chief guest, Vaidya Jayant Dev Pujari sir, Chairperson, Board of Governor, CCIM New Delhi. I would like to welcome our patrons of this seminar and management team of our college, Shri D.C. Patil sir, Chairman, Gramin Ayurvedic Medical College, Tevda, Dr. J.B. Alagur sir, Secretary, Gramin Ayurvedic Medical College, Tevda, and Shri Nilesh Desai sir, Treasurer, GAMC, Tevda. Next, I would like to welcome our beloved principal sir and president of this webinar, Gramin Ayurvedic Medical College, Tevda, Dr. L.M. Biradar sir. Welcome you all, sir. I would like to welcome the organizing secretary of this webinar, Dr. Pankaj Patil sir, Associate Professor, Department of Shalaka Tantra, Gramin Ayurvedic Medical College, Tevda. Now, I would like to welcome our chief guest speakers of this webinar, Dr. Shriti Giwari, Madam, Assistant Professor, Department of Shalaka Tantra, Gramin Ayurvedic Medical College, Tevda. Dr. Preeti Patil, Madam, Assistant Professor, Department of Shalaka Tantra, Gramin Ayurvedic Medical College, Tevda. Dr. Shrikant P. Nambudri, sir, Chief Medical Officer, Sridharayam Ayurvedic Eye Hospital and Research Center, Kerala. Dr. Anjali Shrikant, Madam, Consulting Physician and Senior Medical Officer, Department of Panchakarma, Sridharayam Ayurvedic Eye Hospital and Research Center, Kerala. Dr. Satish Hadimani, sir, Associate Professor, Department of Shalakya Tantra, SGR Ayurvedic Medical College, Ayurvedic Mahavidyalaya, Solapur, Maharashtra. Dr. T.R. Shantala Priyadarshini, Dean and HOD, Department of Shalakya Tantra, Sairam College, Bhopal, Madhya Pradesh. Dr. Muralidhar Badige, sir, Professor and HOD, Department of Sharir Rachana, Gramin Ayurvedic Medical College, Tevda. Dr. Shamsaz Fayaz, Professor and HOD, PG, Department of Shalakya Tantra, National Institute of Ayurveda, Jaipur, Rajasthan. Dr. K.S. Sangoli, sir, Professor, Department of Shalakya Tantra, Kahes Shri BMK Ayurvedic Mahavidyalaya, Belgaum. It is my duty to welcome our teaching staff, non-teaching staff, hospital staff, and students of Gramin Ayurvedic Medical College, Tevda. I would like to welcome all the media personnel, registered participants, faculty members, practitioners, UG students, PG scholars of different colleges across the country. Welcome you one and all. Thank you.
Thank you, sir. Shubham Karoti Kalyanam Arogyam Dhana Sampadam Shatru Buddhi Vinashaya Deepam Jyoti Namostute. We will have our tradition auspicious lamp lighting ceremony as a tribute to Lord Dhanvantari, the god of medicine. So I request our secretary, Dr. J.B. Algur sir, and treasurer, Sri Nilesh Desai sir, to lighten the lamp.
Off.
Thank you one and all for inaugurating today's webinar by watering the plant and lighting the lamp. Now I like to welcome our today's chief guest, Vaidya Jayant Dev Pujari sir, Chairperson, Board of Governor, CCI, New Delhi, to address this gathering.
Dhanvantare Namaha, Shri Gurubhyo Namaha. I must first congratulate to the team of Shalaka department of Gramin Ayurved Medical College for organizing such a wonderful webinar on the subject which is very important from practice point of view also. As I am practitioner, I am more interested in the practice of Shalakya Tantra, more in the public, that is out of the institution practice of Shalakya. Nowadays, it is getting popular day by day, and now we are finding some Ayurvedic Netra Chikitsak, Ayurvedic ENT specialists at many places, particularly in big countries. And I think it should spread like this, and it will spread like this, because if we look at this subject, then even in modern medicine, it has changed the form. Now all these surgical procedures, particularly in Netra, they are at OPD level, that is daytime care, day care system. So we are opting for the new instruments, and we are using new instruments, and so many new things are coming in this. So I request all Shalakya persons to opt for these new things, because instruments we can use, yes, surely. Another area which is important is we must understand how we can use Rasayana in Shalakya. Because Shalakya is not, for Ayurveda, Shalakya is not only surgery. Yes, degree is MS Shalakya, but still we have many options even in the Kai Chikitsa part of Shalakya. So I request all the distinguished practitioners and the teachers who are present in this webinar and the students also, and particularly PG students, to look into this matter also. Say, for example, for uh, a simple action of Brahma, we have many options in medicine, and for this, we need not go for any type of surgery. But yes, if it is related to current, then can we use rasayana? Because basically it is the aging process for because of which this Brahma Lakshan appears when it comes to ENT, because it appears in many conditions. But when it comes under ENT, then there are limited options for that. So can we do something, or can we come up with a solution for such type of lakshanas which are important for the patients? So that you have to think over it. Surgical procedures, they are changing every day. Many laser techniques and even other advanced techniques, they are coming in the market. So how we can opt and how we can adopt in our institutes as well as in our private practice, that is more important. In Netra Chikitsa, our balasthan is not only instruments, because instruments come from modern. Our balasthan is the medicine which we prescribe after any type of surgery or any type of challenge. So many of our Shalaka people who are working in Netra Roga, they are using this very fantastically. And I know few of the practitioners of Netra Roga who are doing very well along with the surgical procedures. They don't use even a single allopathy medicine, and still they are doing very well in the Shalaka practice, that is surgery part of it. So I once again congratulate to the organizers to uh, organizing such a webinar. What I am seeing it here is nearly 216 participants I am seeing on my screen. So this is really like a confidence. It is not only we call it webinar because one person spoke and the others they hear. But with this much number, you can call it as a conference also, web conference you can say. So once again, I congratulate to the organizers, and the list of the distinguished speakers which I heard, they are really expert in their domain. And today will be the feast for this Shalakya students to hear their experience, their expertise in this webinar. And it will be a great day for them. That is what I personally think. Once again, I thank the organizers for giving me this opportunity to join this webinar, at least for the inauguration session, because I have some other meetings, so I will leave this webinar. But it would have been a pleasure for me to be here to hear the experts' view on this subject. I once again thank you to the organizers, and namaste to all of you. Namaskar.
Thank you, sir, for addressing this event, sharing and blessing us with your valuable words and thoughts. Thank you. Thank you, sir. Thank you one and all for attending this inauguration function of National Webinar on Jnana Shalaka 2020. Let us start the today's sessions. न चोरहार्यम न च राजहर्षम न भ्रातृभाजम न च भारकारी विवेक कृते वर्धत एव नित्यम विद्याधनम सर्वधन प्रधानम. It cannot be stolen by thieves, nor can it be taken away by the kings. It cannot be divided among the brothers. It does not have a weight. It's spent regularly. It always keeps growing. The wealth of knowledge is the most superior wealth of all. यस्तु संचरते देशान यस्तु सेवते पंडितान तस्य विस्तरति बुद्धि तैलबिंदु अंबुसी. The intelligence of a person who travels in different countries and associates with the scholars expands, just as a drop of oil expands in water. To expand our knowledge, let us start our discussion with the scholars. The first session is by Dr. Shruti Givari Madam on the topic physioanatomical aspect of retina. To introduce our first speaker, Dr. Shruti Givari Madam, I request Dr. Shiv Prasad Pasmani sir to introduce Madam to all.
Thank you, sir. Dr. Shruti Givari Madam is born on 28th April 1990. She has completed her BAMS and post-graduation degree from Sri JG Cooperative Hospital Society, Ayurvedic Medical College, Hospital and Research Center, Ghataprabha. At present, she is working as Assistant Professor in the Department of Shalaka Tantra, Gramin Ayurvedic Medical College, Tirda. Madam has total experience of 2.5 years. Madam has presented many paper presentations in many national and international seminars.
Thank you, sir. We will start the first speech by Dr. Shruti Givari Madam. Over to you, Madam.
Good afternoon, everyone. Myself, Dr. Shruti Givari, Assistant Professor. Good afternoon, everyone. Myself, Dr. Shruti Givari, Assistant Professor, Department of Shalaka Tantra, Shri Bahubali Vidyapith, JV Mandal, Gramin Ayurvedic Medical College, Tirda. First of all, I would like to thank sincerely to our management and principal, sir, of Gramin Ayurvedic Medical College, Tirda, for giving me an opportunity for the guest speech in this national webinar on Jnana Shalaka 2020. Today, I am dealing with the topic physioanatomical aspect of the retina. As we know about anatomy of eyeball, eye is one among the sensory organ. Eyeball is composed of 3 layers. The outer tunic of the eyeball is fibrous coat, that is sclera and cornea. Middle tunic is vascular coat, choroid, ciliary body, and iris. The innermost tunic is known as nervous coat, that is retina. Today we will discuss about the third layer, retina. Retina is the innermost tunic of the eyeball. It is thin, delicate, transparent membrane. It is the most highly developed tissue of the eye. Retina will appear purplish red in color. The outermost layer of the eyeball is sclera. The middle part is choroid. The innermost layer is retina. The yellow circular part of the eyeball is known as nervous coat, that is retina. Mainly 3 parts in the nervous coat: optical part, ciliary part, iridial part. These 3 are nervous coat, 3 parts. First one is optical part. Optical part is posterior part of the retina. It is sensitive to light. And ciliary part, posterior part of the ciliary body, and it is insensitive to light. Third one is iridial part. posterior part of the iris. It is insensitive to light. Retina extending from the optic disc to ciliary body. The junction between retina and ciliary body is known as ora serrata. Retina has two surfaces. Outer surface is related with choroid and inner surface is related with vitreous humor. It is not directly related with vitreous humor. A membrane is present here that is known as hyaloid membrane. Gross anatomy of the retina. Here retina extends from optic disc to ora serrata. It is the thickest in peripapillary region and thinnest at ora serrata. Thickest means 0.56 mm and thinnest means 0.1 mm. Surface area of about 266 mm square. And regions. Retina has three distinct regions. First one is optic disc, second one macula lutea, third one is peripheral retina. In that first one, optic disc. Optic disc shape appearance in optic nerve head where the optic nerve enter the eyeball. Well-defined circular area of about 1.5 mm diameter. Color may vary, means pale pink in color. All the retinal layers terminate here except the nerve fibers which passes through the lamina cribrosa into the optic nerve. And optic nerve appears pale due to lamina cribrosa and absence of vascular choroid. Cup varies in size, shape, position, and depth in the two eyes. Next is physiological cup. Physiological cup is a depression seen in the center of optic disc, where the central retinal vessels emerges. Increase in the size of cup or difference in the size of cup of the two eyes should be properly examined to exclude glaucoma. In this physiological cup, there is absence of rods and cones, so there the light rays going to converge. So image is not going to form. So this is known as physiological blind spot. Next is macula lutea. Macula lutea is a lateral to optic disc. There is another circular depression known as macula lutea. It is comparatively dark area, 5.5 mm in diameter and situated at the posterior pole of the eyeball and temporal to optic disc. And it is also called as yellow spot or fovea centralis. Its primary function is photopic vision. Fovea centralis is a central depression in macula and measure in 1.85 mm in diameter and 0.25 mm in thickness. It is most sensitive part of the retina. Next is fovea. Fovea is a central depressed part of the macula and photoreceptors are present here. The cone which helps for perception of light. The cones are present in fovea centralis. The rods are present at peripheral part of the macula lutea. The lowest threshold for light and highest visual acuity because it contains only cones. Next is foveola. Foveola is a shining pit in the fovea centralis. Its diameter is 0.35 mm and situated above two disc diameter away from the temporal margin. A tiny depression in the center of foveola is known as umbo, which is seen shining foveal reflex on fundus examination. An area about 0.8 mm in diameter doesn't contain any retinal capillaries and called foveal avascular zone. The third distinct region is peripheral retina. It increases the field vision and divided into 4 regions. First one is near periphery. Near periphery is 1.5 mm around area centralis and mid periphery is 3 mm wide zone around near periphery. Far periphery from optic disc 9 to 10 mm on temporal side and 16 mm on nasal side in the horizontal meridian. Next is ora serrata. Ora serrata is a peripheral margin where the retina ends and ciliary body starts. 6 mm nasally and 7 mm temporally from limbus. 6 to 8 mm from limbus, 25 mm from optic nerve on nasal side. Next is retinal layers. Mainly retina is composed of 2 layers. The retina is basically derived from diencephalon. Usually from diencephalon, optic cup will produce. This optic cup have outer lining and inner lining. The outer layer get converted into inner pigment epithelium. The inner layer get converted into neuronal layer. And there is no any junctional complex between these 2 layers. So these layers are not so sticky. In outer pigment layer, it consists of pigment epithelium and photoreceptors. And inner sensory layer consists of bipolar neurons and optic neurons, that is ganglion cells. Histologically, retina composed of 10 layers. It has 10 layers: retinal pigment epithelium, layer of rods and cones, external limiting membrane, outer nuclear layer, outer molecular layer, inner nuclear layer, inner molecular layer, ganglion cell layer, nerve fiber layer, and internal limiting membrane. These are 10 layers of retina. In this diagram, first upper brown color line is there, that is pigment epithelium, and second layer is rods of cone. These purple and green projections are called as rods and cones. And external limiting membrane, third layer is external limiting membrane. Then outer nuclear layer and outer flexiform layer. The outer flexiform layer is the bipolar cells and photoreceptors make a synapses that is known as outer flexiform layer. And the bipolar cells and ganglion cells make a synapses. That layer is known as inner flexiform layer. The nuclear of rods and cones are arranged in one row, that is known as outer nuclear layer. The bipolar nerve cells and cell bodies are arranged in a row, that is known as inner nuclear layer. The ganglion cell bodies make a row, that is known as ganglion cell layer, and nerve fiber makes a layer, that is known as nerve fiber layer. Then external limiting membrane and internal limiting membrane. Retinal pigment epithelium, it is the outermost layer of retina. It is the first layer of the retina which is adherent to choroid. And it is the outermost layer of the retina and made up of a single layer of hexagonal cells. These cells contain pigments. It is firmly adherent to underlying brush layer and loosely attached layer of rods and cone cells. The subepithelial space, that is potential space between retinal pigment epithelium and retina. The retinal detachment. The detachment means separation of the retinal pigment epithelium from the retina. Subretinal fluid, the fluid between sensory retina and retinal pigment epithelium. Retinal pigment epithelial cells are connected to each other by zonule occludents and zonule adherents. The functions of retinal pigment epithelium. Photoreceptors get renewed and recycling of vitamin A. Maintain integrity of subretinal space and transport of nutrients and metabolites. The mechanical support to the processes of photoreceptors. These all are the functions of retinal pigment epithelium. The second layer is layers of rods and cones. The rods and cones are the end organs of vision and also known as photoreceptors and are arranged in palisade manner. Rods are 120 million and cones are 6.5 million. The rods contain a photosensitive substance, visual purple, that is rhodopsin, and subserves the peripheral vision. The vision of low illumination, that is scotopic vision. The cones contain photosensitive substance and primarily responsible for highly discriminatory central vision, that is photopic vision or color vision. Structure of rods and cones. Rods are of 40 to 60 micrometer in length and cylindrical, highly retractile and transversely striated and contains visual purple. And rod has perules. In bottom, the rods have a projection that is called as spherules. Next, in cones, cone cells 40 to 80 micrometer in length and largest at fovea and shortest at periphery. It contains iodopsin, and it has cone pedicle, that is cone foot. In lower, there is some projection that is known as cone pedicles or cone foot. Third layer is external limiting membrane. From optic disc to ora serrata and becomes continuous with the basal lamina between the pigmented and non-pigmented portions of the ciliary epithelium. Functions are selective barrier for nutrients and stabilization of position of the transducing portion of photoreceptors. Next, fourth layer is outer nuclear layer. It contains soma and nuclei of photoreceptor cells and width varies. Nasal to optic disc, there is a 45 micrometer space is there and 9 to 8 rows of nuclei are present. And temporal to optic disc, 22 micrometer in space and 4 rows of nuclei are present. At fovea, 50 micrometer space is there and 10 rows of rods and cones are present. Next, rod nuclei are orange in color and cone nuclei are red in color. The different nuclei can be differentiated because of nuclei stains with Mallory stain. Rod nuclei forms the bulk of this multi-layered outer nuclear layer, exception in fovea region. Next is outer flexiform layer. Outer flexiform layer is a synapsis between rod spherules and cone pedicles with dendrites of bipolar cells and processes of horizontal cells. Marks the junction of end organs of vision and second order neurons in retina. Thickest at macula, 51 micrometer, consists of predominantly of oblique fibers that have deviated from fovea and also known as Henle's layer. Next is inner nuclear layer. It is a very thin layer and disappears at fovea. It consists of bipolar cells, horizontal cells, amacrine cells, soma, and Muller cells. Next, bipolar cells. Bipolar cells are 2-degree neurons in visual acuity and 3 crore 56 lakh and 76 bipolar cells are present and oriented radially. 9 micrometer at fovea and 5 micrometer at periphery. And horizontal cells are flat cells having numerous horizontal associative and neural interconnections. between photoreceptors and bipolar cells in outer plexiform layer. Unlike bipolar cells, information is relayed radially through the retina. Horizontal form a new network of fibers that integrate the activity of photoreceptor cells horizontally. In that, first one is horizontal neurons. It consists of following cells: the flat cells having numerous horizontal associative and neuronal interconnections between photoreceptor and bipolar cells in the outer plexiform layer. Amacrine cells are present in the innermost of this layer. They have a piriform body and single process. It forms connection with the axons of ganglion cells. Next is Muller cells. Muller cells are the nucleus and cell bodies are within the inner nuclear layer. They provide structural support and contribute to metabolism of sensory retina. Retina contains other glial cells like astrocytes, microglial, and oligodendrocytes. Next is inner plexiform layer. It consists of synapses between axons of bipolar cells and dendrites of ganglion cells. Inner plexiform layer is in this amacrine cells also mediate interactions within the layer, and the interplexiform cells receive input from the amacrine cells, and also contains processes of Muller cells, abundant microvasculature, occasional displaced nucleus of a ganglion or amacrine cells. This layer is absent at fovea. The inner plexiform layer is absent at fovea, and its thickness is 18 to 36 micrometer. And more synapses per unit area is more than 2 million per mm square. Next is ganglion cell. Eighth layer is ganglion cell layer. Mainly composed of three cell bodies. These are called as third order cells. Others are other processes of Muller cells and other neuroglia. Branches of retinal vessels are also present. The layers and its situation of ganglion cells. The single layer of ganglions are present at peripheral retina. Double layer ganglion cells are present at temporal side of the optic disc. 6 to 8 layers of ganglion cells are present at edges of fovea. At fovea and optic nerve head, ganglion cell layer is absent. Next is nerve fiber layer. Nerve fiber layer is a unmyelinated axons of ganglion cells. It converges at optic nerve head and passes through lamina cribrosa. It becomes ensheathed by myelin posterior to lamina cribrosa. Its nerve fiber contents are axons of ganglion cells, that is centripetal nerve fibers. Second one is centrifugal nerve fibers, means it is thicker than centripetal. Processes of Muller cells with interweave with axons of ganglion cells. One is neuroglia cells present in nerve fibers. Retinal vessels do not project on surface of retina, rich bed of superficial capillary network. Arrangement of nerve fibers in retina. In nasal half directly to optic disc as superior and inferior radiating fibers, and in macular region passes straight in temporal part of disc as a papillomacular bundle. The temporal retina arch above and below the macular or papillomacular bundle as superior or inferior arcuate fibers. Internal limiting membrane. Internal limiting membrane is the innermost layer and separates the retina from vitreous. It is formed by the union of terminal expansions of the Muller cells fibers and essentially a basement membrane. Collagen fibrils, proteoglycans, basement membrane, plasma membrane of Muller cells and glial cells. These all are present in internal limiting membrane. Next is blood supply of retina. The outer 4 layers are supplied by choriocapillaries, choriocapillary network, and inner 6 layers are supplied by central retinal artery. Retina is supplied by central retinal artery and enters the optic nerve on lower surface, that is 15 to 20 mm behind the globe. The retinal arteries are end arteries and have no anastomosis at ora serrata. Next is physiology of retina. In physiology of retina, light falls on retina, that is retinal pigment epithelium will not scatter the light rays that will send the impulses to photoreceptors. The photoreceptors send the impulses to bipolar neurons, that is first order neurons. These will send the first order neurons will send the impulses to ganglion cells and fibers. And these are the second order neurons. These second order neurons will send the impulses to lateral geniculate body, that is third order neurons. Then through their visual impulses reaches the visual cortex, then we will get the clear image. Next is physiology of vision. Physiology of vision is a complex phenomenon which is still poorly understood. The main mechanism involved in physiology of vision are initiation of vision, that is phototransduction, and the transmission of visual sensation. Third one is visual perception. In that, first one is phototransduction. The rods and cones serve as a sensory nerve endings for visual sensation. Light falling upon the retina causes photochemical changes and changes which in turn trigger a cascade of biochemical reactions that result in generation of electrical changes. Photochemical changes occurring in the rods and cones are essentially, photochemical changes occurring in the rods and cones are essential. This whole phenomenon of conversion of light energy into nerve impulse is known as phototransduction. In this phototransduction, the photochemical changes will turn to rhodopsin belching, and two mechanisms will occur in this, that is rhodopsin belching and rhodopsin regeneration. Next is transmission of visual sensation. The light absorbed by rods and cones pigment, that will photochemical changes takes place and electrical impulses are arise. Information is forwarded through ganglion cells, then ganglion cells to optic nerve, and through their optic chiasma and optic tract, then lateral geniculate body and optic radiation, then visual cortex. The receptor potential transmission of the visual impulses, the receptor potential generate in the photoreceptor is transmitted by electronic conduction to other cells of the retina. Those are horizontal cells, amacrine cells, ganglion cells. However, the ganglion cells transmit the visual signals by means of action potential to the neuron of geniculate body and lateral to primary visual cortex. Next is visual perception. Functional elements of vision, that is, those are light sense, form sense, contrast sense, and color sense. First one, light sense, appreciation of light. The form sense, most acute at fovea. Contrast sense, differentiate between luminance which are not separated by definite borders. Color sense, discriminate between the colors. Next is visual pathway. The optical system must transmit the images cleanly without interruption to the retina. which transforms light into electrochemical signals for transmission through the visual pathway to the visual cortex. Visual pathway is made up of axons, which connects retina to the occipital lobes of the brain at the level of visual cortex. The pathway starts at retina, then proceeds from the orbit through the optic disc, along the optic nerve to join with the optic nerve of the other eye at the optic chiasm. Information then passes to the lateral geniculate body and finally reaches the occipital cortex. The conclusion. Retina is an innermost layer of the eyeball. Microscopically, it is composed of 10 layers, and retina is responsible for the visual perception. Hereby, I conclude my today's topic on physioanatomical aspect of retina. Thank you, one and all.
Thank you, madam, for sharing your knowledge with us. If you have any questions, you can put them in the chat box. Questions will be taken at the end of today's all sessions. So now we will move on to second session by introducing our second speaker, Dr. Preeti Patil, madam, on the topic etiology of diabetic retinopathy. So I call Dr. Shivaprasad Pasmani sir to introduce madam.
Thank you, Sachin sir. Dr. Preeti Patil, madam, is born on 1st June 1998. She has completed her BAMS from Gramin Ayurvedic Medical College, Terda, and post-graduation degree in Shalaka Tantra from Ashwini Ayurvedic Medical College, Hospital and Research Center, Tumkur. At present, she is working as assistant professor in the Department of Shalaka Tantra, Gramin Ayurvedic Medical College, Terda. Madam has total teaching experience of 1.5 years. Madam has presented many papers, presentations in many national and international seminars.
Thank you, sir. Next, we will start our second session. Over to you, madam. So, madam, diabetic retinopathy.
Om Namah Siddhaya. Good afternoon to all. Respected patrons, respected Vaidyajan Dev Pujari sir, respected principal sir, organizing secretary of this fourth semi-webinar, respected delegates and staff and students. I will start my presentation. Today my topic is etiology of diabetic retinopathy. Before I start topic properly, I would like to take your attention towards the prevalence of the diabetes mellitus. Okay. The World Health Organization estimated that global prevalence of diabetes among adults over 18 years of age 8.5% in 2014. There are 72.96 million cases of diabetes. Next. There are estimated 72.96 million cases of diabetes in adult population of India. The prevalence in urban areas ranges between 10.9% to 14.2%, and prevalence in rural area 3% to 7.8% among the population aged 20 years and above, with much higher prevalence among individuals. Diabetes and diabetic retinopathy have been emerging as significant non-communicable disease leading to ocular morbidity. It is estimated that diabetic retinopathy was responsible for 1% of blindness and 1.16% of visual impairment globally. According to Harrison Principle of Internal Medicine, 19th edition, the definition of diabetes mellitus is the group of common metabolic disorders that share the phenotype of hyperglycemia. Okay. The complications of diabetic mellitus related to, they are divided into two types, vascular and non-vascular complications. They are similar in type 1 and type 2 diabetes. In the non-vascular complications includes infections, skin changes, and hearing loss. I will concentrate on the today's topic. In vascular complications of the diabetes mellitus are further subdivided into microvascular and macrovascular mainly. In microvascular, there are diabetic retinopathy, diabetic neuropathy, diabetic nephropathy. And in the macrovascular complications are coronary heart diseases, peripheral arterial diseases, cerebrovascular diseases. Okay. In the microvascular complications are diabetes specific, whereas macrovascular complications have pathophysiological features that are both shared with general population and diabetes specific. Now we will deal with the retinopathy. Definition of the diabetic retinopathy. Retinopathy means what? First, retinopathy is any damage to the retina of the eyes which may cause visual impairments, vision impairments or visual impairments. Then what are the risk factors of the diabetic retinopathy? We'll go one by one. First one is the duration of the diabetes. Duration of the diabetes is most important determining factor. Roughly 50% of patients develop diabetic retinopathy after 10 years and 70% after 20 years and 90% of the people after 30 years of the onset of the disease. Second one is the sex. Incidence is more in females than in males with the ratio of 4:3. And poor metabolic control is the less important than duration, but it is not nevertheless relevant to the development and progression of the diabetic retinopathy. Fourth one is heredity. It is transmitted as recessive trait without sex linkage. The effect of heredity is more on the proliferative diabetic retinopathy. Fifth one is pregnancy. Pregnancy may accelerate the changes of diabetic retinopathy. Sixth one, hypertension. Hypertension, when associated, may also accentuate the changes of the diabetic retinopathy. Next, we'll move to the pathogenesis of the diabetic retinopathy. Pathogenesis, according to Ayurveda, we'll consider Samprapti, that is the Samanya Netraloga Samprapti, that is Siranusari Vidoshai Vignai Rudamagato Jayante Netravageshu Roga Paramadarunaha. According to the Shrutacharya Uttara Tantra, third chapter shloka. This is the Samprapti of the Netraroga, Samanya Netraroga, according to Shrutacharya. But when we are going to the pathogenesis of the diabetic retinopathy in the modern, that is the hyperglycemia, high blood sugar level in the vessels, that is the microvasculars, or it may be microvessels. There will be after the hyperglycemia, there is the oxidative stress, inflammations are occur, PKC activation, that is the protein kinase C activation, and AGE, that is the advanced glycation end products, and another one pathway is there, that is polyol pathway. See, simple is that it is interesting. In hyperglycemia, high blood sugar levels in the blood vessels of the retina, the sugar molecules which are higher in the blood vessels of the retina. The cells which are endothelial cells which are present in the retina, they are not, these are the insulin independent. These does not want insulin to enter the sugar molecules from the blood to the cell bodies or cell membrane. Okay. That's why what happens, there is the endothelial cells, these are does not want insulin. That's why there is the direct entrance of the sugar molecules to the endothelial cell membranes of the retina. Then there is the, as an end product, protein kinase C activation will be takes place, and advanced glycation end products and inflammations will be takes place. There is the activation of cytokines and growth factor. Other growth factors are VEGF, like vascular endothelial growth factors, like growth factors will be released. Okay. After the activation of the PKC, protein kinase C activation of cytokines and growth factors will be released. By the releasing of the VEGFs, there will be a thickening of the capillary basement membranes. Here we can see the thickening of the capillary basement membrane. And next, capillary endothelial cell damages will be occurred. Changes in the RBCs, that is the Rolex formation of the RBCs, like that. Increased plasma viscosity, by that stickiness of the platelets will be takes place, and loss of capillary pericytes. This is very important. Loss of capillary pericytes. Pericytes are the surrounding membranes of the retinal endothelial cells. Loss of capillary pericytes will be lead to the formation of the microaneurysms. Okay. Due to these factors, there will be a microvascular occlusion takes place. After the microvascular occlusion, retinal ischemia, that is the retinal hypoxia or retinal ischemia. Okay. This is pathogenesis of the diabetic retinopathy according to the modern science. According to the Ayurveda, Siranusari bir doshai vignai rudamagato jayante netra bhageshu roga paramadarunaha. As my opinion, Siranusari bir doshai means doshas, vitiated doshas which are moved from the Urdhva Marga. There will be a vitiated dosha which are moved from the Urdhva Marga and vitiate the Jayante Netra Bhageshu. Netra Bhageshu means, as the commenter of Dallana we have taken, Netra Bhageshu, Netra Avayaveshu, whatever it may be. The Netra Bhaga, it may be Klira, it may be choroid, or it may be retina. We will take the Netra Avayava, that is Netra Bhaga. Jayante Netra Bhageshu Roga Paramadarunaha. This is the Sira. Here they are taking the Sira. Sira means they are taking as a veins. Okay. There is the venous occlusions, or vein occlusions also lead to the retinal ischemia. Next, we will move to the symptoms. The mainly patients are complaining of the floaters, which are seen the mainly three symptoms are there: floaters, decreased visual acuity, curtain falling over eyes. I will explain one by one. In floaters, according to Sushrutacharya, Drishtigata Roga, there is the Dvitiya Patalagata Roga, Drushtirbusham Vihalati Dutiyam Patalam Gate, Makshika Mashakana Keshan Jalakani Cha Paschati. Floaters are seen like a Makshika Mashakana Kesha Jala. There is the network-like structure which is seen in front of the patients. They are complaining about the small dots which are moving like a sanu parts alla ಓಡಾಡ್ದಂಗೆ ಆಗ್ತಾವ ಅಂತ. Second is decreased visual acuity. That is the Pratama Patalagata Timira. Avyaktani sa rupani sarvaneva prapashyate. That is the Pratama Patalagata Timira. There will be a blurriness of the vision. There is the blurred vision. In any part of the, there is the two types of vision, central vision and peripheral vision. It may be seen in the central or it may be seen in the periphery. If periphery is there, no, there is other reasons are there. In central means it will attack on the macular part. Third one is the curtain falling over the eyes. The curtain falling over the eyes, that is the, according to Sushrutacharya, that is Tratiya Patalagata Timira. Mahantachipe Rupani Chad Ativa Vasasa, Taniva Vasasa. There is anything Vastra is Chadati. There is the curtain falling over the eyes. The patients are complaining about the curtain falling over the eyes. Signs. Mainly 5 signs are there in the diabetic retinopathy. First one is microaneurysms, retinal hemorrhages, exudates, retinal edema, neovascularization. We'll now see one by one. First one is microaneurysms. Microaneurysms are localized outpouchings, mainly secular, of the capillary wall that may form either by focal dilation of the capillary wall, where pericytes are absent, fusion of the two arms of the capillary loop. Loss of pericytes may also lead to endothelial cell proliferation with formation of the cellular microaneurysms. In picture, we can see the microaneurysms. Thus, this is the fundus photoangiography. You can see the small dots. These are the tiny red before slide. These are the tiny before slide. Here in the OCT, we can see the tiny red spots, red dots. Often initially, these are seen temporal to the fovea, may be indistinguishable clinically. We will indistinguishable clinically from the dot hemorrhages. Microaneurysms are different and hemorrhages are different. Okay. In the fundus fluorescein angiography, it is called as a fundus fluorescein angiography, FFA, allows the differentiation between dot hemorrhages and non-thrombosed microaneurysms. Early frames show tiny hyperfluorescent dots, typically more numerous than visible clinically. Late frames show diffuse hyperfluorescence due to leakages. This is the one investigation method for the diabetic retinopathy, hypertensive retinopathy, macular edema. In so many diseases, we can use the FFAs. Next, retinal hemorrhages. Retinal nerve fiber layer hemorrhages arises from the larger superficial precapillary arterioles and assume their characteristic shapes because the architecture of the retinal nerve fiber layer is different. We know, our madam is told, that is retinal nerve fiber, the expansion of the retinal nerve fiber, how the retinal axons which are goes to nerve fiber to the optic disc. This is the architecture of the retinal nerve fiber is different. Layer of the nerve fiber is different. Intraretinal hemorrhages arises from the venous end of the capillaries are located compact middle layers of the retina. As a result, we will see the red dot and blot configuration. Red dots are different and blot hemorrhages are different. Deeper dark round hemorrhages represents the hemorrhagic retinal infarcts are located within the middle retinal layer. The extent of involvement is significant marker of the likelihood of progression to the proliferative diabetic retinopathy. Next, exudates. Exudates are distinguished from the older term of the cotton wool spots. The exudates are junction of the normal and edematous retina. The exudates composed lipoprotein and lipid-filled macrophages, which are located mainly within the outer flexiform layer, that is the fifth layer of the retina. And these looks waxy yellow lesions, which are relatively distinct margins arranged in clumps or in rings. There is the difference between the hard exudates and soft exudates. In hard exudates, the ill-defined margins are there. In soft exudates, there is the margins are, we will define the margins clearly. On fluorescein angiography, you can see the large dense exudates. Retinal edema, due to the plasma viscosity, there is the secretion of serous fluid in between the retinal layers. We can see here, this is the OCT picture of the retinal edema, that is central serous retinopathy, and the hard exudates, which are surrounded in the macular area. And fifth one is neovascularization, that is the due to VEGF factor, that is the vascular endothelial growth factor. There will be a formation of new vessels over the retinal internal limiting membrane. You can see neovascularization here also. These are the grids. Next, we'll move to the classification of the diabetic retinopathy. There are many classifications are there. One among that, first one is, there are 4 types are there: non-proliferative diabetic retinopathy, proliferative diabetic retinopathy, diabetic maculopathy, and advanced diabetic eye diseases. See, first we will start with the non-proliferative diabetic retinopathy. Ophthalmic features of the non-proliferative diabetic retinopathy includes mainly, non-proliferative means there is no proliferation of the new vessels over the retina. Microaneurysms in the macular area. This is the earliest detectable lesion of the NPDR. Second one is retinal hemorrhages, both deep and superficial. Third one is hard exudates, which are yellowish white waxy looking patches arranged in the clumps or succinate pattern. Succinate means in the circular pattern. These are commonly seen in the macular area. And fourth one is retinal edema, characterized by the retinal thickening. Fifth one is cotton wool spots are composed of the accumulation of the neuronal debris within the nerve fiber layer. The result ischemic disruption of the nerve axons and swollen ends, which are known as cystoid bodies seen on the light microscopy as globular structure in the nerve fiber layer. And venous abnormalities, that is beading, looping, and dilation. That is the beading means when beading, looping, and dilation. Intraretinal microvascular abnormalities, that is IRMA, intraretinal microvascular abnormalities. These are the anatomical shunts which are connects between the retinal arterioles and retinal venules. Dark blot hemorrhages representing the hemorrhagic retinal infarcts. On the basis of the severity of the above findings, NPDR is further again classified: mild NPDR, severe, moderate, mild, moderate, severe, and very severe. In mild NPDR, at least one microaneurysm or intraretinal hemorrhage is there. That is mild NPDR. Hard or soft exudates, it may be present or may be absent. Moderate NPDR. In moderate NPDR, microaneurysms and intraretinal hemorrhages are there. Hard and soft exudates are present or absent. The third one is severe NPDR. That is any one of the following. In retina, there are mainly 4 quadrants are there. In 4 quadrants, in 2 quadrants we have seen venous bleeding, and in 1 quadrant we have seen the IRMA, that is intraretinal abnormalities, microvascular abnormality changes, and in 3rd quadrant severe microaneurysms are there. In the very 4th classification is very severe NPDR, that is the 4-to-1 rule. We will call it as a depending upon the quadrants. In 4 quadrants of the retina, we will see the severe microaneurysms and intraretinal hemorrhages. And in 2 quadrants, we have seen the venous bleeding. In 1 quadrant, we have seen the IRMA, that is intraretinal microvascular changes. The second type is in the diabetic retinopathy, that is proliferative diabetic retinopathy. Proliferative diabetic retinopathy develops in more than 50% of cases after about 20 years of the onset of the disease. The hallmark of PDR is occurrence of the neovascularization is very important. Neovascularization over the changes of very severe non-proliferative diabetic retinopathy. It is characterized by proliferation of new vessels from the capillaries in the form of neovascularization near the optic disc or elsewhere. It may be neovascularization elsewhere. That is we call it as a NVD, neovascularization in the optic disc, neovascularization elsewhere. Elsewhere means it is over the retina. It may be in the temporal region, it may be in the superficial, inferior, and nasal. In the PDR, again we will classify PDR as 2 types. PDR without high risk classification characteristics, PDR with high risk characteristics. In PDR without high risk characteristics, what happens? There is the high risk characteristics means NVD, neovascularization near the disc. Over the disc, 1/4 part of the disc, we will see the neovascularization with vitreous hemorrhage and retinal hemorrhages. Without characteristics means neovascularization is only in the 1 part of the disc, that is the 1/4 part of the disc, without hemorrhages and without pre-retinal hemorrhages. Third type is diabetic maculopathy. Diabetic macular edema occurs due to increased permeability of the retinal capillaries. Diabetic maculopathy is the most common cause of the visual impairment in diabetic patients, particularly in the type 2. The fluid is initially located between the outer plexiform layer, inner nuclear layers. Later, it may also involve the inner plexiform layer and nerve fibers layers until eventually the entire thickness of the retina becomes edematous. In the macula, this will occur in the macular region. The fluid initially located in between the outer plexiform layer and inner nuclear layer, that is the 5th layer and 6th layer, and next again 6th layer to 7th layer. There is the inner plexiform layer to the nerve fibers layer. The accumulation of the serous fluid. That's why there is the edematous. There is the macular edema, maculopathy. Clinico-angiographically, diabetic maculopathy again classified into 4 types. First one is focal exudative maculopathy. It is characterized by the microaneurysms, hemorrhages, macular edema, and hard exudates. Here, one thing we will remember, that is circinate pattern of the hard exudates are there. Circinate means circular pattern of the hard exudates we can see. Second one is diffuse exudative maculopathy. It is characterized by the diffuse retinal edema and thickening throughout the posterior pole. There are 2 parts of the retina, posterior pole and peripheral pole. That is, in the posterior pole of the retina, we can see the thickening, diffuse thickened retinal edema, and few hard exudates we can see. Ischemic Third one is ischemic maculopathy. Here, there is the microvascular blockage. Microvascular ischemia is there. Clinically, it is characterized by the visual loss. With the microaneurysms, we can see microaneurysms, hemorrhages, and few hard exudates. Fourth one is mixed maculopathy. Mixed maculopathy means it has combined feature of the ischemic and both exudative maculopathy are present. Last type, that is advanced diabetic eye diseases. It is the end result of the uncontrolled proliferative diabetic retinopathy, and it is marked by the some complications are there. There are persistent vitreous hemorrhages, fractional retinal detachment, and neovascular glaucoma. These are the complications of the advanced diabetic eye diseases. Okay. Investigations. What are the investigations we will do in the diabetic retinopathy? Urine examinations, blood sugar examinations, estimations, FFA, fundus fluorescein angiography should be carried out to elucidate the areas of neovascularization, leakages, and capillary non-perfusions. And last but not the least, that is optical coherence tomography. It is very important. Nowadays, we are doing the OCT machine. We are doing the OCTs. That is the invasive test of the all the layers of the retina with the help of the invasive machine, with the help of the machines. In the FFA also, we are injecting the fluorescein dye to the brachial artery. It will go to the carotid artery, and next the branch of the carotid artery, that is ophthalmic artery, next go to the central retinal artery, and we can take out the pictures or take out the videos of the FFAs. Okay. Thank you. Thank you. Thank you.
Thank you, madam, for sharing your knowledge with us. If you have any questions, you can put them in the chat box. Questions will be taken at the end of all the sessions. Let us start third session by introducing our third speaker, Dr. Shrikant Nambutri sir, on the topic Ayurvedic management of diabetic retinopathy. So I call Dr. Shivaprasad Usmani sir for introduction of Shrikant Nambutri sir.
Thank you, Sachin sir. Dr. Shrikant P. Nambutri sir, the younger son of Dr. NPP Nambutri sir, is the epitome of the vision of Sridharayam modern eye care rooted in Ayurveda. After his graduation, Dr. Shrikant sir completed his post-graduation in Shalaka Tantra, the Ayurveda equivalent of ophthalmology, and become proficient in modern diagnostic techniques in ophthalmology. He joined Sridharayam as a director, clinical research, and was integral in realizing the Ayush Granted Center of Excellence in Ayurvedic Ophthalmology at Sridharayam, and was co-investigator to his father, Dr. NPP Nambutri sir, in all the projects. Following his father's footsteps, Dr. Shrikant sir joined Indian System of Medicine Department as a specialist medical officer in 2014 in Netraloka, and excelled in this position and was at the helm of various state government projects till he rejoined Sridharayam after his father's demise. Dr. Shrikant sir is currently the Chief Medical Officer at Sridharayam and Secretary of Sridharayam Ayurvedic Research and Development Institute. Along with extensive clinical experience in treatment and management acquired from various positions he held. Dr. Shrikant sir has shown his multifaceted skills as managing editor to the in-house journal Netra Mitram and the indexed scientific journal Sridharayam Vision. Welcome you, sir.
Hello. Namaste. Good afternoon. Hope I am audible to all of you.
Kindly unmute yourself.
Good afternoon all. Can I start? Somebody was telling something.
Now audible.
Now audible. It's okay now? So good afternoon all. Namaste. So first of all, let me express my sincere gratitude towards the organizers of this 4th national webinar, Jnana Shalaka, organizing by Gramin Ayurveda Medical College, Kardal. And let me thank my colleague, Dr. Sheetal Sadalagi, who has invited me as a part of this seminar. And again, thanks all of you for including me in this session as a speaker in the topic of management of diabetic retinopathy. Let me start with, let me thank our pre-speakers, Dr. Sudhi and Dr. Preeti, who made my task little more easy, because the basic things like the retina anatomy, physiology of retina, and the etiopathogenesis of diabetic retinopathy, these all things are the basic things before going for the management, as we all know that. So they made my task little bit more easy. And thanks to the coordinators and all the organizers. Let me just share my presentation screen.
मैडम क्वेश्चन बड़ा कर रहे हैं.
Hope the screen is shared comfortable. I think it is. Everybody can see this. All right. Hello.
Yes, Shrikant, you do one thing.
Yeah, tell me.
Give it a slideshow.
Slideshow in the sense?
It's there in the right corner. Is it PPT? It is PPT, no?
PPT.
Okay, you either you do one thing. You press F5.
5.
F5.
It is in the big screen only now.
No, it is not there. It is not in the slideshow. Or else you click on, you do one thing, double click on the screen, on the PPT.
Yes, here it is showing it is in the screen only.
So, what has done is you have
Sir,
done.
do one thing, enable editing, sir. Click on enable editing. And the top bar at the PPT, sir.
So you have a protected view.
Yeah. Oh, understood. Yeah.
Then you can give a slideshow.
Oh, I think it is okay.
Yeah, sir. Right.
Yes. Continue.
Sorry for the delay. Little bit weak in the technical aspect of Zoom. I'm sorry. So first of all, let me just tell you one thing. Management of diabetic retinopathy. I just added here it as traditional practices in the management of diabetic retinopathy because I may be adding some of the traditional medicines or some of the traditional treatment methods which we follow here, especially in Kerala. That may be also will be included in this presentation. So that's what I just added this heading it as traditional practices in the management of diabetic retinopathy. See, retinopathy, as our previous speakers, they were telling, retinopathy, it's nothing but a retinal vascular complication of diabetes mellitus and leading cause of blindness in industrialized nations, more common in type 1 than type 2. Risk factors of diabetes mellitus, and due to the poor glycemic control, this can come. Because of age, this can progress due to the pregnancy, hypertension, hyperlipidemia, smoking. Because of all these reasons, this retinopathy can be affected for those who are affected with the diabetes mellitus, or it can be progressed. See, as per the status by the Association of Prevention of Blindness from WHO, in 2015, it's almost adults living with the diabetes, it's plus 415 millions, and the expected score in 2040, they were expecting it as 642 millions in 2040. So this is the condition which we face in case of diabetes mellitus. And as we all know that once a man has diagnosed with the history of diabetes mellitus, one or the other way, he is supposed to be under a regular follow-up just to understand that it has not been affected with the other organs like eye or other nephro-related things or neuropathy or any of the other complications. Coming to the classification of diabetic retinopathy, as the just immediate speaker, past speaker was explaining about the classifications of retinopathy, the same thing only, I will be trying to explain it here. The first one is non-proliferative retinopathy. Next is going to, there is only change. I have added this maculopathy in the second one, and proliferative diabetic retinopathy as the third one, and the advanced diabetic diseases. And see, the features of non-proliferative diabetic retinopathy are nothing but these all things are there in the slides, and I'll be going a little bit fast. Microaneurysms, dot and blot hemorrhages, these all things are with the clear-cut video and photos. The other speakers were already explained that. And exudates will be there, cotton wool spots, venous abnormalities, and IRMA. And in maculopathy, there can be swelling in the retinal vessel, retinal nerves, and retinopathy at the macula, vision-threatening edema or ischemia. These all things can happen, and the people will be going into a stage called something like the central portion of the vision may be obstructed. And coming to the proliferation of the diabetic retinopathy, neovascularization of the disc and retinal hemorrhages, and in advanced diabetic eye diseases like retinal detachment, posterior vitreous hemorrhage, neovascular glaucoma. And we'll be going first into the management of non-proliferative diabetic retinopathy. Of course, this is a picture of non-proliferative diabetic retinopathy. As you can see that microaneurysms, soft exudates and hard exudates and intraretinal microaneurysms. Here, the objective of the treatment is non-proliferative diabetic retinopathy, the selection of medicines according to the other complications or conditions. Why? Because in diabetes, most of the cases, this can be, the people can be associated with some other systemic things like either hyperlipidemia or any other system generated other diseases. These all factors in the management, these all factors are, all things are considered under for selection of the medicines. And in non-proliferative retinopathy, this is the first, this should be considered as the first stage of diabetic retinopathy. In this, as I was just telling you, microaneurysms, all the other clot hemorrhages, all the things will be there. Before going deep into the management of diabetic retinopathy, there should be a management. We should make sure that there should be a management for diabetes mellitus. That's what Prameshakara Chikitsa I have added here. And next to the retinopathy, Kapha Medokara Chikitsa has to be applied. And the Sthanika Chikitsa. Sthanika Chikitsa means nothing but the Netradhara like Segam or Aschodanam. These all things are to stabilize the blood vessels for further, I mean, to avoid the further, further complications towards maculopathy or other proliferation of the vessels. See, the objectives and steps of the treatments comes under prevention. Prevents the condition from progression to the next stages. As we all know that, I mean, once this non-proliferative retinopathy has diagnosed with man, according to the modern sciences, there is not much effective treatment, and nothing will be offered for that managing that retinopathy, because this stage has to be progressed towards other things like maculopathy or macular edema. Then only the intervention of injections like Avastin, Lucentis, all these things, there is a role. So then once the non-proliferative retinopathy has diagnosed, most of the cases in allopathy side, they will, I'm not telling that they will be neglecting, they will wait for the progression of the disease. The only thing that we can do is the control of diabetes mellitus. That's what Pramekakara Chikitsa. Controlling the diabetes, that is a major, that has got a major role in this, the management of non-proliferative retinopathy, that it should not progress towards the next stage. And Kapahara Chikitsa, Abhishandahara and Kledahara Chikitsa, Deebana, Pajana, Rutshana, and there is a significant role for the Pathya for controlling the diabetes. See, for the Pramekakara Chikitsa, there are some of the choice of medicines I just added here. And if you want, I will be sharing this presentation. I think these all things are recorded in the platform. And Kashayas like Nisa Katakadi Kashayam, it is explained in Sahasra Yoga. Kataka Khadiradi Kashayam, that is also explained in Sahasra Yoga. And Gudikas like Chandra Prabha Gudika, Kaishwara Guru. Megas, it's nothing but it's a patent product which is prepared from the Sridhariya Mulli. And Nisha Amalaki tablet. Nisha is nothing but Amalaki, you know that. And churnams like Kashyapa Churnam, that is the combination of Triphala, Estimadu, and Jeevanti. And Virajana with the Vara Churnam mixed with the Swarna Patri. Kapha Medohara line of treatment. The other Kashayams like Varanadi Kashayam, Amrotrigam Kashayam, Gugulu Uttan Kashayam, and Gudiga, Triphala Gulu, Amrita Gulu, Kanjanata Gulu. And there is one capsule which is prepared from our own pharmacy, that Colbate capsule for this is for, see, why Kapha Medohara Chikitsa, because why I'm included in this controlling of the other along with the Pramekakara Chikitsa, why there is a significant of, because there can be some of the obstructions in the blood vessels. So lipids or fat contents may be there. That has to be eliminated from the. So there is a importance for managing the other systemic diseases too. Nasyam with the Pradimarsa Nasya, Anadailam Shirabala. External therapies, Takradhara. You may be, or people may be heard about the treatment called the Takradhara, as Takra means nothing but buttermilk. This will be mixed with the Musta Amalaki Kashayam or Vasha Kashayam or Guluchya the Kashayam. These all things can be used in the management of diabetic retinopathy. These all, the objective of all these treatments are the stage it should not progress towards further. And Talam or Chiro Lebam with Kachura the Churnam or Nimba Amra, Kachura the Churnam with the Nimba Amra the Erenda. And Talabodichil or Shiro Vestanam. Shiro Vestanam may be a new word for you people, because this is the Vestanam, like keeping the paste of medicines externally. In the picture you can see that. And in Talabodichil, that will be covered with the leaf. And choice of medicines are Vasha, Laksha, Esti, Musta Amalaki, or Vasha plus Vasha Gudichadi Kashayam or Triphala Kashayam. Then coming to the Sthanika Chikitsa, Netra Kriya Kalpa like Aschodanam, we'll be going deep into all these ingredients in the coming slides. Netramardam, Netranjanam, Netradhara with the Triphala, Estimadu, Lothra Kashaya. Anjana can be done with the Jadi Muguladi Varti, Chandanadi Anjanam, and Tarpana. Tarpana, most of the cases may not be needed, because before doing the Purva Karmas like other Takradhara, Talabodichal, all the things, sometimes this may not be needed. After Amapajana, only the Tarpana can be done. Because as we all know that, we will be going towards the next session called about the Netra Kriya kalpa, there is an explanation called Anjanam Puranam Kwadapanam Ame Na Sasyade. Like Anjana and Tarpana Podavaga, these all things in the Ama Avastha that should not be applied. So after the Ama Pachana, then only the Tarpana can be done. I will be going towards the one by one medicines. Chandra Prabhavadi. You will be, most of the people will be heard about the Chandra Prabhavadi because most commonly it is used in the management of diabetes. Improvement of insulin action at the cellular level, increasing glucose metabolism and glucose homeostasis, anti-diabetic activity of the ingredients, insulin sensitizing, regeneration of beta cells, antioxidant action it has got, and influencing insulin resistant and altering carbohydrate metabolism. And coming to the Nisha Amaliki tablet, and significant lowering of glucose, and it has got one more activity called action called antioxidant activity, and protective against nephropathy and cataract and hyperlipidemia. And some of the reference which is already added in these slides about these drugs. Pharmacodynamics of the medicines used, like the patent products I was explaining, this is a medicine which is prepared from our own pharmacy, Meghasri. Haridaki Vibhidaki Amaliki. It has got the anti-inflammatory, antioxidant, and anti-diabetic properties. And Haridra again acts as base of Megha by reducing kapha, reduces inflammation by acting on pitta, reverses insulin resistance by acting on vata dosha. And again, it is continuing to go through and Nimbardi, again, ingredients of Meghasri capsule. Netramrtam and Netranjanam, I was explaining the alam, spadiga, which we use for pacifies pitta and kapha. And the levana, this spadiga, I mean, it has, the levana is vital for balancing sugar levels in diabetes. And its sushma nature help it to absorb and enter minute pores. This is one of the other Ghrida I was explaining in the after Amapachana, the Tarpanam, Vasa, Sariba, Guduji, Estimado are the ingredients, and its action has already, you can read that antibacterial, antimicrobial, wound healing properties of Vasa and Sariba, anti-inflammatory, antioxidant, and hyperglycemic, anti-hyperglycemic activity of Guduji, and Estimado acts as Chakshushi and Pittahara. And Anjana, the pharmacodynamics, when we explain about in the case of Anjana, means there when once Rasakriya or paste which we use for this Anjana, there will be more absorption rate and less disposal. Permeable through, I mean, by acts on the posterior segment disorders, because once the tissue contact time is more, it can cross the retinal barrier. Again, Nasya, as we all know that Nasaka Sirasodwaram, nerves from the head extend towards nose by reaching Sringada Varma. Medicine exerts efforts on channels related to eyes, ears, nose, and throat by expelling doshas. Andaila is one of the example for that can be, there is a choice, that is a choice of medicine used for Nasya. Clinical outcome of moderate NPDR. This is a study which is a single case study which is done in our institution, in our research and development institute. After 3 months gap of non-proliferative thing, in the marked area, you can see that clot hemorrhage, the blood hemorrhage which is not there, that has disappeared, and the size of that hemorrhage has also reduced. It's a single case study, just I had added in this slide, just for the understanding purpose. Going towards the second classification, diabetic macular edema. I will continue my presentation because the coordinators were explaining that the questions will be answered in the last of after finishing all the 4 sessions. Diabetic macular edema. This you can see a picture of macular edema. This can be a common cause of visual impairment in type 2 diabetes, and diffuse and focal. Diffuse extensive capillary leakage will be there in case of diffuse, and focal leakage from microaneurysms and dilated capillary segments associated with X-rays. Further accumulation like cystoid macular edema. It will be forming in the form of a cyst. See, clinically significant CSME, clinically significant macular edema, grade 1. Grade 1. See, you can see three pictures like grade 1, retinal thickening at or within 500 micron of the fovea. Grade 2, retinal thickening with hard oxalates or within. Grade 3 is thickening of one disc diameter or larger in size. So this is a what I can say, the classification of again macular edema, how extent it has got, and immediately maybe after the treatment, the post treatment, how much it has reduced. For calculating all these things, this classification has made. Again, the objectives and steps for management of macular edema is, first one is kapha pitta shamaka chikitsa, amapadana, shodhakara chikitsa. As there is a swelling over the retinal layer, shodhakara chikitsa has got a major role in managing this macular edema. See, these are some of the choice of medicines for managing macular edema as internal medicines like Sonidamrdam Kashayam, Samira Banjan Kashayam will be coming into the next slide. I mean, this is once again a patent product from our own pharmacy. Buluchadi Kashayam, Lekhu Vasadi Kashayam, Mahavasadi Kashayam, Mahamanjistadi, Tribhala Gugulu, Chandra Prabha, Kumari Swarasa. These are a choice of oral medicines in the management of macular edema. See, coming to the therapies which we used for macular edema, Vidalaga. As we all know, Vidalaga is nothing but the Vidalaga Behirlebo Sahadevi Tulasi Surasa with honey. It's a choice of medicines which can be used in Vidalaga. The Sahadevi and Harida ki churna mixed with the Erenda Taila. Pindi, Alampushan, Manduka Varni. This can be used. Anjana, Jadi Muguladi Varti, Chandanadi Varti, Aschodana, Durva Krida. This Durva Krida, it has got the ingredient called Ajat Shira. This Shira has got again a vital role in managing this macular edema. One, we need to understand that once the case of macular edema has diagnosed, the other part, before the condition was non-proliferated retinopathy, we should expect some of other clot or dot hemorrhages. Sometimes it may be there in most of the cases. So both the management has to be done, because it should not again, once the patient has come to our OPD as diagnosed with macular edema, or we diagnose it as macular edema, it should not progress towards the proliferation. That's what the intention for the treatment. Avipatti Churnam is a choice of medicine for the Virajana, and Vasti. Vasti has got a other major role in managing this macular edema, because now this presentation I had already been presented in All India Institute of Ayurveda Delhi, which after that this Vasti with the Punarnavadi Kashayam and Gomutra, one trial has already been started there. I remember. With Guguluttan Kashayam, Guruchadi Kashayam, Gomutra, Lekhu Vasagadi Kashayam, Gomutra. These are again choice of medicines for doing Vasti. Shiro Levam Talam, Shiro Veshna. Haridagi, Punarnava, Amalaki, with Pala Kashayam, Vasa Lakshadi Churna, Amalaki, Mustain, Vasa Guluchadi Kashayam, the Kartavat Amalaki in Vasa Kashayam. These all things, because this the powder and the kashayam will be mixed together, and that is again used in the form of talam or shirolevam or shiroveshna or talabudich. It's a choice of medicine only I just added here. I think most of your students, and this will be helpful for your future for practicing this thing, because I don't want to tell you that all these medicines has to be applied for managing a single individual diagnosed with the macular edema, because these are the choice of medicine which has got a good result which we see. Again, Vasagulichadi Kashayam or Mustamalaka Kashayam with the Takradhara Kashayam, doing as Takradhara. Paranadi Kashayam can be used as Shirodhara. Again, this is once again a single case study which we did here in the last year. Before treatment, after a gap of 2 months, the edema, you can a significant change. You can see it in the next, after treatment picture. Shonidamritam Kashayam. These are the ingredients of Shonidamritam Kashayam. Sariba, Nimba, Pathya. The actions of these all ingredients have got anti-diabetic, anti-inflammatory, antioxidant, antibacterial, wound healing property. These all actions of these individual drugs will act together, managing this retinopathy, especially in case of macro. Which reduces the cholesterol, helps to maintain weight and fights obesity, and pacifies kapha and pitta, maintains digestion and absorption. See, again, mode of action of therapies, which I was explaining you, like Talabudichil, Shirolebam, Takradhara, these all things like Talabudichil and Shirolebam, it reduces the pitta and rekta, absorb the leakages in retina, and Takradhara, it indicated in Mutra Dosha. Musta and Amalaki, two key ingredients, the antioxidant and anti-inflammatory properties of Musta Amalaki will in Takradhara will be acting more. Indian Bidalaga, external pressure on the eyelids causes vasodilation, so that the blood can move further, and there will be less chance of obstruction of the blood vessel. Allows for the expulsion of toxins. Going towards the third stage called pre-proliferative and proliferative diabetic retinopathy. Pre-proliferative. Just before, immediate past speaker was very clearly explained that the picture with the other good pictures better than this about the neovascularization hallmark features. You can see clearly in the picture neovascularization or the formation of new capillaries or blood vessels. Since there is a obstruction in the main vessel, there can be formation of other blood vessels or capillaries. The objectives of managing this pre-proliferative diabetic retinopathy: avoid advancing to proliferation. See, once this pre-proliferative stage of diabetic retinopathy has affected to an individual, people will be having extensive problem for vision, like they will be seeing some of blood streams in their vision, and one or the other way they will be approaching a doctor, either to us or to other modern people. So in that stage, what can be done is they will be advised to go for the vitrectomy, all the things. So before that, what we can do is try to convince the patient to avoid advancing to the proliferation, and surgery if can be avoided, because once the vitrectomy, all the things had already been done, then there can be a limitation for, of course the treatments can be adopted for the people those undergone for vitrectomy, but the action of medicines or therapies may be a little bit less comparing with the other those who are not undergone for the surgeries. Jwarahara Chikilsa, Vata Pitta Samaga Chikilsa, Urthoga Rekta Pitta Chikilsa. Rekta Pitta Chikilsa, Madam Preeti, Madam has explained that because Urthagata Rekta Pitta, the diabetic retinopathy, the prameha and its management complications, all the things we have, we will be getting maximum of references in most of the textbooks, classical Ayurveda. But the management of diabetic retinopathy, it may be difficult to get because there are very less literature. So the Urthagata Rekta Pitta means there will be flowing of blood towards the Urthaga part that has to be absorbed. So this retinopathy also the same pathology will be happening, and this treatment can also be act for managing this diabetic retinopathy. Pre-proliferate. Principles are nothing but similar to the macular edema. Anilomena, pitta, virejana, sodo, shodha, ropana. It's healing. Vasa has got a major role in managing this retinopathy. See, internal medicines, other than already explained in the diabetic macular edema, those all medicines can be used. And addition to that, Pamiravanjan Gashayam, Gugulu Panjavalam, Akshabejadi Gashayam, Saptamardhan Gashayam, Vasa, nothing but Arathoda Vasika. Bahya Upacharas, external therapies, Talam, Shiroveshram, Takradhara, the same treatment methods will be acting in this. And I'm stick on to the same type of, ingredients like Vasha Lakshadi Churna or Vasha Gulichadi Kashayam. So Vasha Lakshadi Churna, Amaleki Musta. Again, Vasha Gulichadi Kashayam with the Takram can be applied in the form of Takradhara. And for the forehead labum, Amaleki boiled and made paste with the milk. Going to the proliferative retinopathy. Management similar to that of Urthagata Rakta with the principles of Vada Raktagara Chikilsa, Jara Chikilsa or Pandugara Chikilsa will be applied in this thing. In this picture, you can see the proliferation, you can see, and there is a traction detachment also. The proliferation, once if we do not treat that proliferation the right time, this can lead to the detachment. Detachment again, it is again the structural deformity which has happened. Maybe my experience, I'm telling. Of course, most of the other scholars or my teachers are also there. Those who have got a good result in managing this retinal detachment. But once the retinal detachment it has had, it may be a little more difficult to manage that condition. Because since that attachment of retina it has detached, then again it has to be attached. The medicines has got a very less or slow action towards managing this detachment. But the proliferation can be stopped by doing all these treatments like Takradhara or Talabodichilandol with the help of Vasa Tripalandol. Precautions, headrest with the head slightly tilted up because the circulation again towards the Urtaga part, it has to be avoided. And avoid yoga practicing pranayama because again the pranayama, all the things as we all know that this will the circulation will be it will be increased more. It will be increased more. That again the circulation can lead to that part, and there is a chance of again and again bleeding from that. So we advise should not the yogasanas like inward movement of head. Those all things has to be avoided. Diet control, avoiding abhishanda, kara ahara, not lift heavy weights, take extra care while prescribing and administering procedures like Shirodhara, because Shirodhara and all the patient will be on the supine position. So that again, there is a chance of going circulation can be more and bleed. There is a more chance for bleed. Medications can be used like the same thing which I told you, extra. Addition to that, Samiravanja Akshavijadi and all Chandana Uchiradi Kashayam, Drakshadi Kashayam. These all things, Drakshadi Kashayam, which is explained in Vadacharam, Shastra, Uluchadi Kashayam. Amarda Shadanka Kashayam, Jara Chikilsa, Sahasra Yogam has explained, Diktaka Kashayam, Vada Pitta Shamaka, Duralabhadi Kashayam, Vasha Gulichadi Kashayam, Laksha Siddhat Shiram, Sadavari Swarasa with Laksha with the honey, Vasha Swarasam, and the diabetic powder. Again, going to that other ingredients of powder and Samana Nasya for Stambana with the Drona Pushpi, Virajana with the Gandharva Hastadi Eranda, Vasti again has got a major role in treating this proliferation of retinopathy. Tripala Guduchadi Kashayam, Vasha Tripala Kashayam. Therapies are Haschodanam, moringa or Lucas aspera eye drops. Sega or Netradhara with the Durvat Shira Kashayam, Lotha Estimate, Pindi with Guduji, Kumari, Chandana, Vidalaga with the tender coconut nut paste, Ichumula the Porambada, Levam with the Sahadevi Kalkam, Laksha Churnam mixed in mud pot, Shiro Veshno Talabadachil with the Draksha, Prabondariga, Shadavari, Laksha, Vasha, St, Vasha Gudichadi Kashaya or Mustamali Kashayam, Shirodhara. No need of using any of the oil. The kashay itself can be used in Shirodhara. Takatara with the Vasha Gudichadi Kashay, Shirodhara, St, Shira, Shirodhara. Lebam with the Vasha Lakshadi Churnam or in Vasha Gudichadi Kashay. Proliferative retinopathy in complications. Saptamardam Kashayam or Lakshadi Gulu, Saptamardam Krida with the Varachurna, Sega. Vinayaka Anjanam again is a combination with that Shira. Leva, Lejaluan, Sahadevi, Tarpana, Ja. Chachushevasti. Because Ashtangriya, Kalpa Siddhistana, it has explained that Chachushevasti pacifies Apana and Vyanavada, regenerates capillaries and improves blood flow. Virejana expels accumulated kleda from Costa reduces hemorrhage. Costa Shodhana used as Pradiloma Gada Chikilsa. Madhumehajanya Netraroga is similar to Urthogara. Madhumehajanya Netraroga is similar to Urthogara Rektavita. Because once the proliferation has happened, then again the Prameha has turned into the stage called Madhumeha. Therapies like Jalayoga Charana also can be applied on the temporal region for site of complications. Thaniga, Srodoshuddhi. Retinous inflammation, pus discharge, heaviness, something it is there. If at all any of these symptoms are there, this can be used. Explaining about Samira Panchagam Padam or Kashayam, Yava, Musta, Chandana, these are ingredients of this Kashayam. I already explained in the previous slides. See, this is the picture which I had shown you before starting that proliferation. We could see that, I mean, the blood which is there, that has absorbed back. But the band which is there, that is the detachment. So there is a limited changes only we can see in the aspect of detachment. But the blood which is there, it has what I can say, that all things could absorb after a gap of, must see this, 3 years. It's a red-free image of the same thing. See, again, the proliferation, the blood which is there, you can see very clearly after a gap of 1 year, the vitreous hemorrhage which was there previously, that is not there. Complications. Retinal detachment, it's a most common complication of retinopathy. Sir, other choice of drugs can be used in Saptamardam Kashayam, Akshabijadi Kashayam, Saptamardam Kritam, Sega with Darvit Shira, Mrityugadi Kashayam, Vinayaka Anjanam, Pushpa Bandhana. Lajjalu with Sahadevi for labum over the frontal part. Mukkadi Gudiga, which is explained in Sahasrayoga. Karattavat Tarpanam or Ashwadhanam with the Jadavedak. Piosis irid is to be open. These are some of the medicines can be advised in managing this thing, but the iridis and all managing the result will be very minimum, which you got. Sega Pindi Talabodichil Nitya Virejana. Going to the classification and management of diabetic retinopathy here going to be ended, and I'm going to the last session, like some of the clinical research outcomes which the research has done it in our own institution. Incidence of report of various stages of diabetic retinopathy at Caesareum from 2015 January to 2019 October. It's almost, 76% were male people, and out of 100, it is only 23.3% of female. 2015 again, yearly outcome that you can see it in 2019 it has become 22.5%. NPDR, in the pie diagram, you can clearly make out this. These are the reported cases. The total number of patients were 1,973, of which 40% were NPDR, diabetic macular edema with the 20.4% and 26.7% diagnosed with the PDR. Advanced diabetic retinopathy was 12.1%. See this picture. It's not. This is according to the statistics which we received it from Kerala. The cases reported from different states of India. But in that it is showing it's 993 people from Kerala. Maybe the institution has situated, the head office is situated in Kerala, Ernakulam district only. Maybe because of that, most of the people have come from 993. And this is the overall statistics as it's we received the patients we received here. But this cannot be shared for other presentations because this is a statistics which we received in Kerala only. Prospective study on mild to moderate NPDR from 2010 to 2012 outcomes. Study to assess the efficacy of Ayurvedic treatment in patients with NPDR. Number of subjects were 50. The study was for 1 year, and significantly in the histogram you can see the central retinal thickness has reduced from, it's an average mean value like 316 microns to 242. Visual acuity, a logmar grade which is noted here, like before it was 1.2 visual acuity, and total symptom score were total symptoms which other associated symptoms, it was from 9.43 to 7.1. Retrospective analysis, it's just taken in for 1 year, 2018. A total 735 cases were admitted for diabetic retinopathy during the reference period. A total of 350 patients were selected randomly for analysis. Baseline and endpoint analysis was done on median visual acuity chart, and before treatment it was 6/60, and after 1 year it became 6/24. By 60, 6/24, and this is the visual acuity reading I am telling you. It's not a accurate parameter to assess in the management of assess the clinical outcome of management of diabetic retinopathy. This is a statistical data on specific treatments in treatments which are used in managing this NPDR. 226 people are started, and Anjanam 100%. The sheet I will be sharing it for you. The same graph. In case of PDR, this is Astrodhanam 90% use of Sahadevi Sarasa, because Astrodhanam, we all know that Astrodhanam is Sarvesham Akshiroganam Ado Astrodhanam Hidam. Whatever may be the eye diseases, Astrodhanam has the first thing has to be applied, as Acharya says. This is a histogram of that. So with this, let me conclude my session. And next is my wife, Dr. Anjali. She will be joining in the same page only. And now I request the admin to take over the mic. Thank you all for patient hearing.
Thank you, sir. Thank you, sir, for sharing your views and thoughts on the topic. Questions will be taken at the end of today's session. Let us begin with the fourth session by introducing our fourth speaker, Dr. Anjali Srikanth Madam, on the topic practice of Kriya Kalpas in Netra. So I request Dr. Shivprasad Usmani sir to introduce Madam.
Thank you, Sachin sir. Dr. Anjali Srikanth ma'am is a senior medical officer and heads of the Panchakarma division of Sridharayam. Panchakarma is an essential therapy for all diseases in Ayurveda, and eye diseases are not an exception. Dr. Anjali did her post-graduation in Panchakarma and is adept in treatment of both eye disease and general elements using this therapy. She has also lent her hand in research at Sridharayam as a senior research fellow in the projects at the Center of Excellence. She has also completed her MBA in healthcare providers. She has published articles in reputed national and international journals. She carries a clinical experience of over 16 years in the field of Ayurveda. Welcome, June.
Namaste. Good afternoon, all. Is it audible?
Yes, madam. Yes.
Good afternoon, all. First of all, I extend my gratitude to all the organizers and coordinators of Jnana Shalaka 2020 for giving me such an opportunity. Thank you all. And today my topic is, I will be sharing my screen. Is it visible?
Yes, madam.
So today my topic is Netra Kriya Kalpa, practice of Netra Kriya Kalpa. So directly we can go for the session. First we can see the importance of Kriya Kalpa. It's told that Sarvendriyanam Nayanam Pradhanam, that among all sense organs, eye is very important, just like how the sun is important among all celestials. The Dharani Harayuktanam Jyotisham Eva Bhaskara, that much important is the eye. So all treatments which cures the eye ailments and also which helps to improve its health is also very important. So while thinking about the treatment principles of eye, that first and foremost is Sankshepada Kriya Yogo Nidana Parivarjanam. No doubt that avoiding of the cause is the first and foremost treatment principle. But while considering the treatment modalities, we will get that Anda Parimarjana, that is internal medications, Bahi Parimarjana, external medications, and also that Shastra Pranidhana, surgical management. And this, our Kriya Kalpa comes in Bahir Parimarjana. And why these topical measures are important? When the drugs are administered systemically, many of the drugs cannot cross the ocular barriers, that is blood aqueous, blood vitreous, and blood retinal barriers. But when topically these medicines are used, they can reach the target organ more easily because of the direct tissue contact. And medicine even can bypass the systemic circulation also, and that bioavailability also will be more. So with all these reasons, along with that internal medicines, that our ocular therapies are also very important in the management of eye diseases. Types of Kriya Kalpas. According to Charaka, Aschodana, Anjana, and Vidalaka, Sushruta only 5, Tarpana Pudavaka, Seka, Aschodana, and Anjana, and Sharangadara, Yoga Ratnagara says 7. Seka, Aschodanam Pindi, Vidala, Tarpanam Tadha, and Pudavaka, and Anjana. So what is the aim of Kriya Kalpa? Just like our Ayurveda aim, Swastasya Swasthirakshanam, Aturasya Vikara Prashanam, same is that of our Kriya Kalpas also. Netra Prasadanartha, that is for maintaining the health of a healthy eye, and also Netra Roga Shamanartham, for treating the eye ailments. And classification of Kriya Kalpas. While doing the classification of all Chigilsa, Chigilsa is of only 2 types, Dvidhopakramaniyam, that is Langhana and Brahmana. Same in case of eye, that is one is Ama Chigilsa and Nirama Chigilsa. For understanding this, we have to know what are the Ama Lakshanas of eye and what are the Nirama Lakshanas of eye. So let's go. Ama Lakshanas are Udirna Vedanam Netram, Raga Shopa Samanvidam, Karsha, Nistoda, Shula, Ashruyuktam, Amanvidam, Vidu. That means severe pain, Raga, reddish discoloration, and Shopa, swelling, foreign body sensation, different types of pains, and lacrimation. These are Ama Lakshanas. And Nirama Lakshana is nothing but the subsiding of all these Lakshanas, that is Manda Vedanada, mild pain, and Manda Kandu, that relieving of itching, and even Samrambha, foreign body sensation also relieves, and reduction of lacrimation, inflammation, and the eyes will be Prasanna Varnada Chakshno, that eyes will be attaining its natural color. And what all the Netraja Amahara Chigilsa? In a condition of Ama, that is Raga, Shobha, like that symptoms, when all these symptoms are seen, we have to go for Seko Dinani Chatwari, that means Seka, and even Svedana, different types of lepas, and Pitta and Madhurasa Aharas, along with Langhana and Pajana. That again references are there. Akshi Kukshi Bhavorogo, Pradishyaya Vranajara, Pajane, Panjede Panjaratrena, Prashamam Yandi, Langhana. Langhana is the first and foremost treatment for Akshi, Kukshi, Rogas. Also Pradishyaya Vranajara and all. So Langhana is the first line of treatment for these Ama conditions. And again, there are reference Anjana, Purana, and Kwadha. Anjanam, Puranam, Kwadhapanam, Ame Nashasyade. In those conditions of Ama, we should not go for Anjana. Purana is nothing but both Tarpana and Pudapaga. And also Kwadhapana. Kwadhapana is contraindicated in Ama Avastha. By this, we can conclude that among 7 procedures, 7 Kriya Kalpas. The first 4, that is Seka, Aschodana, Pindi, and Vidalaka, is for Ama condition. And Acharya clearly says Anjana Purana should not be done in Ama condition. That means it is for Nirama condition or for Brahmanartha. This Anjana, Tarpana, and Pudapaka. And we can go through all the 7 procedures one by one. First is Seka. Sekastu Sukshma Dharabhi. That means uninterrupted flow of medicine should be there. And Sarvesmin Nayane Hita Militakshasya Martyasya. That means it should be done in closed eye. And Pradeya Chadurangulat. It should be dropped from a height of 4 angula. When to do Seka? It can be done even Purvane, Aparane, Madhyane, and Rujakale. At the time of disease, we can do this Seka. And there are 3 types, Snehana types of Seka for Vadaja, Ryopana for Pitta and Rekta, Lekhana for Kapha. And drugs of choice are for Snehana. We can use medicines which are Koshna, Snigdha, and Madhura Amla Lamana, just like Sarpi, Majja, Mamsa, etc. For Ryopana, healing property, we can use Shita, Kashaya, Tikta, and Madhura Dravyas. Just like examples are Stanya, Ghrita, Madhu, etc. And even Lekhanartha also, Koshna and Kadutikta Kashaya Dravyas, Rajata, Tamra, Shankha, Vidruma, Samudra Phena, Mastu, Saindhava. All those things can be used for Lekhana purpose. And Samyak Sega Lakshanas are relieving of all Ama symptoms. That is Yoga Nivrti, Swabhavika Varna, Karya Padutum. That is perfectness in the function of the part, and Vedana Shanti. Vedana is not only the pain, all types of Vedanas, symptoms. Some Seka yogas are Seka medicated with milk prepared of Erandatwak and Erandapatra, and Aja Dugdha is very commonly used, especially in Vadaja conditions. Seka with medicated milk prepared from Lothra, Yeshti can be used. Here also that Ajakshira is widely used. And Seka with this same Ajadukta prepared out of Tribhala, Manjishta, Kamala, grinded with water, and can be used in Pittaja and Rektaja Abhishyandas. And disposal rate is more. Absorption is very less because there is no direct tissue contact. It is poured over the eyelids, and it is so absorption is very less. The effect of Seka can be achieved by the thin continuous stream. It stimulates the nerve endings, increases the peripheral circulation, and it relieves the obstructive exudations and reduces inflammatory lesions. Next, we can go for Aschodhanam. Sarvesham Akshiroganam Adau Aschodhanam Hidam. In every disease, the first line of treatment we can go as that Aschodhanam. And Aschodhana is nothing but Aschodhanam Netra Madhye Tailadi Kshepana Rupam. Dropping medicament into the eyes is called as Aschodhanam. And it should be done in the Netra Madhya, at the middle of the eyes. And Ashtanga Hridaya also opines that it can be done even Pijuvartya Kaninige. Even in the Kaniniga Sandhya also we can pour. And it should be poured from a height of 2 angula. And it should be in the opened eye. Unmilide Akshni, that means in the open eye. The eyelids are open with the left hand of the physician, and Vamena Pandina, that with the left hand, physician has to open the eyes, and with the right hand can pour the medicament. Its indication also, Sarvesham Akshirogana Adau Aschodhanam Hidam. It's indicated in Ruk, Toda, Kandu, Harsha, Ashru, Daha, Raga, Nibarhanam. That means nothing but all Ama Lakshanas. And that medicament can be not only some kwadha, it can be kwadha, kshaudra, that honey, asavas, and any type of sneha, ghee, oil, or anything. And binduna, yettupadanam, it should be dropped. Aschodhana kala is usually Aschodhana is contraindicated in night. That means while telling about the mode of action of these Kriya Kalpas, Acharyas explains as Gatva Sandhi Shiro Prana Mukha Srodamsi Bheshajam Urtha Gada. It entails all the Srodasas pertaining to head, neck, nose, eyes, and it draws the malas from there. But in the evening or night time, when due to that tama prabhava, when all the srodasas are closed, we will not get its use properly. That's why our desired effect we won't get. That's why that Ashodhana is contraindicated in night, and morning it can be used in Kaphaja diseases, afternoon for Pittaja condition, and evening for Vadaja conditions. It's also of 3 types. Lekhana, the same type of medicaments which used in Seka, we can use it here also. Lekhana for Kapha doshahara, Snehana Vata doshahara, and Ropana for Pitta doshahara. That 8 drops for Lekhana, 10 drops for Snehana, and Ropana 12 drops. Action: 80% of each drop instantaneously drains through the lacrimal duct. But the absorption, the decoctions are aqueous extracts of different plants, and this material containing active principles is assimilable form. Absorption occurs, and bioavailability is less due to less tissue contact time. Compared to other Kriya Kalpas, it is less. That's only. And comparing Seka and Aschodhana, Yatha doshopayuktam tu nadi prabalamojisa. When the symptoms are less, we can use that Aschodhana, and Sekastu balavattaram. When the condition is severe and symptoms are more aggravated, then we can go for Seka. In some Aschodhana yogas, Aschodhana with Tribhala Kashaya is used in all types of Netra yogas. Aschodhana with Stanya can be used in Vada, Pitta, and Rekta Abhishandas. Aschodhana with Kshira Sarpi or Kshira Navanida can be used in Pittaja and Rektaja Abhishanda. Aschodhana with decoction of Vilvadi Panjamula, Erandamula, Brihadi, etc. used in Vadaja Abhishanda. Next, we can go for Pindi and Vidalagam. Pindi is Yukta Bheshaja Kalkasya, Pindija Kavala Pindi is also called as Pindi Kavaliga Prokta. It is also called as Kavaliga, and the medicated paste is kept over the eyelid and tied with a cloth. Vastra Khandena Sambandhya. That means it should be tied with a cloth, and it is indicated in Netre Abhishanda Nashini. It is also indicated in Netra Abhishanda. Abhishanda is clearly a Amaja condition. So all Ama conditions we can go for Pindi. Again, Netra Abhishanda, Yogyasa, Vraneshvabi Nibadhyate. All Vranas also there will be some Ama Lakshanas will be there. And these are some Pindi yogas. Pindi with Shigru Tok Kalka we are using in Adhimandha, Kalka of Kumari and Guruji as Pindi in Paitika Vigaras, and Erandamula or Eranda Pallava Kalka for Pindi in Vada Abhishanda. Just we can go for a video. Whether that sound is audible?
Yes, madam. Yes, madam. Madam, video sound is not there.
Sterilized ghost and kidney tree. We can apply the paste of the medicine over this cloth and we can just fold it. The therapist should sit comfortably at the head end, and before going for the procedure, we have to clean the surroundings of the eye.
Look on water and then
We can clean the area with lukewarm water and again separately clean that area with a dry cotton.
to avoid the entry of medicine.
Plug the ear with cotton balls.
The sterilized gauze in which the medicine was kept ready should be kept above the closed eyes.
The medicine should be kept over the above the eyelids.
Keeping the medicine, make sure that the eye is completely covered.
The video sound is.
Make sure that eyelid, while keeping the medicaments, that eye is completely closed. Are you audible now?
Yes, madam.
Then are you able to see the video?
Yeah, video is not audible, madam.
Not audible. Okay. Okay. So I will explain and I will skip. Otherwise, that time will be going now. Okay, let us continue. Next is Bidalaga. Bidalaga is nothing but Bidalako, Bahirlevo, Netra, Pakshma Vivarjida. That means it is paste or kalka of dravyas should be kept around the eyes except the eyelashes. And that even powdered drug can be made paste with suitable liquid medium, just like milk, honey, or rose water, or some other particular kashayams. We can make paste, and it should be applied around the eyes, and keep it for a while. We are using usually using this medicines, keeping this medicine for 30 to 45 minutes. And this is also Karyo, Daha, Upadeha, Ashru, Shobha, Raga, Nibarhana. That means all these are also used in Ama conditions. And Tasya Matra Paritnyaya Mukhalepa Vidhanavat. It is that thickness of this paste, it is just like Mukhalepa.
Sliced cotton dipped in lukewarm water and then with a dry cotton. Use separate cotton pieces for each eye. After cleaning the eyes, plug the ears with cotton piece. The medicated paste is applied on the upper eyelid from Kaniniga Sandhi to Abhanga Sandhi, except the eyelashes with
the medicine is applied from the Kaniniga Sandhi to Abhanga Sandhi, except the eyelashes. Just we can see.
Shalaka is a treatment procedure for eye disorders in which lukewarm water from Kaniniga Sandhi to Abhanga Sandhi, except the eyelashes with the thickness of a tamarind leaf. When the medicine starts drying up, approximately after 20 minutes, remove the medicine using a cotton piece dipped in lukewarm water and apply the medicine again. After 40 minutes, remove the medicine using a wet cotton first and then with a dry cotton. We are doing this from Kaniniga to Apanka Sandhi and keep it for first 20 minutes. When it get dried up with some lukewarm water, we are taking it out and again applying it for another 20 minutes. And the types are types of Vidalaga according to thickness of the medicated paste is just like Kalpa. That is 1 inch thickness in Uttama, 1/3 in Madhyama, and 1/4 in Hina. This is of Mugha Lepa, but usually practically we are very thick paste we are applying and it is repeating twice, 20 minutes, 2 sessions, like that we are doing. And Vidalaga and Pindi mode of action. It helps in relieving the inflammatory conditions, congestions, irritations, etc. by vasodilatation. It increases the local temperature and drainage of toxins from the site, and its mechanical effects or pressure helps in reducing the IOP by dilatation of vessels and drainage of aqueous. Medicine is absorbed through the skin of the lid. And these are some Vidalaga yogas. We can use Saindhava Vidalaga for Vadaja Abhishanda. Abhishanda denotes all the ama conditions. So Vadaja in ama conditions which is having predominant all ama conditions which is having Vada predominance, we can use this Saindhavadi Vidalaga, Mamsyadi Vidalaga for Pitta and Rekta, Manohadi for Kabhaja. And in Mukkadi Gulaga, it is very commonly used in Kerala. It is made up of Mukka. Mukka is nothing but Tribhala, Rekta Chandana, Chandana, Rekta Chandana, Haridra, Daru Haridra, Gairiga, Lothra. Like that, ingredients are there in Mukkadi Gudiga. We are very commonly using that Mukkadi Gudiga in this Purampada. Purampada is the name here we are using. And or Bidalaga and Kartavata. Kartavata is also we can use in lid edemas. Next is Anjana. Anjana is Netra eva sthide doshe. That means when the doshas are only pertaining to the eyes. After performing all the Sharira Shuddhi, Kaya Shuddhi and Murtha, that Nasya, Shiro Shuddhi, we can go for the Anjana. Its time of administration is Hemante, Shishire. In those Ridus, Madhyana we can go for, and Grishma and Sharad Ridu in Purvana or Avarana, and Varsha Ridu Nabre when there is no cloud, and Vasande Sadeva we can go for Anjana. It's the common time for Anjana, and there are many types of Anjanas. Based on its action we can classify it as Lekhana, Ropana and Prasadana in general, and Prasadana and Snehana both are one and the same up to some extent, and on the basis of their resa, that 6 resas, and on the basis of the consistency or the type of medicine we can classify as Gudika, Resakriya and Churna, and on the basis of Guna, Mrudu and Tikshna. Gudika is nothing but in the pill form. Resakriya is Resakriya, that Kwadhadinam Punapaga, that again concentrated Kwadhas, just like a semi-solid form, and Churnas are the powder form. So these classification we can consider. And that Anjana, it should be. Am I audible?
Yes, madam.
Shalaka. Shalaka is Vaktrayor Mugulakara. That Shalaka should be in the shape of a flower bird at its tip, and circumference should be of a Kalaya. Kalaya means a pea, and 8 angula long, thin in its middle, and prepared well, regular, and it should be suitable to hold. And one more practice is there, Kurya, Shalakaya or Angulya. We can do even that Anjana with Anguli, but more Shrestha is using the Shalaka. Physician can open the patient's eye with the left hand and holding Shalaka in the right can apply. It can be applied over the Apanga or Kaniniga or Vatmopalevi, that inside the eyelid with the finger also we can do. We can smear it to the inner side of the eyelids. After applying Anjana, without opening the lids, we have to ask the patient to rotate the eyeball for the proper spreading of the medicament. And that opening and closing of the eyes and even squeezing the eyes should not be done. And we should not wash the eyes soon after applying Anjana, because that medicine will be expelled out and proper dosha explanation will not happen, and it may again vitiate the condition, vitiate the eyes. Contraindication. There are some conditions where Anjana should not be done. One is Ama condition, of course. That is again Shrama, Vegavarodha, Udavarta, and Madhyavana, Krodha, and Bhita, Vamita, Jwara. Like that, so many conditions are there where Anjana should not be done. Or in these conditions already that I will be, and in those, if the night sleep is not proper, then in that condition also we should not go for Anjana, because in such conditions already that eyes will be tired and one should not go for Anjana further. We go for that, it again causes some symptoms like Srava, Shula, Shodha, like that. Timida, that means vision impairment, like that. And one more concept is that Pratyanjana, as the Tikshnada of the Anjana is more, if we are using some Tikshna Anjanas to compensate that, some complementary Anjanas, that is, if Tikshna Anjanas are using, we can use some Anjanas which are having Mridu Virya. So that is called as Pratyanjanas. And benefits of Anjana, that disposal rate is minimum, tissue contact time is more, maximum, so that maximum absorption occurs, and it acts as some subconjunctival injection. As it is applied inside these eyelids, it acts such, and also it is permeable to the sclera, thereby acts on posterior segment disorders also. Anjana contains mainly arsenic, that Haratala, Manashila, like that heavy metals, and having large molecular size can enter the scleral circulation, which cannot cross blood aqueous barrier if administered systemically. And drug vehicle and bioavailability, as it is in the semi-solid form, tissue contact time and bioavailability is more. Hence, Anjana is indicated in a variety of systemic diseases such as Mada, Murcha, etc. And next is Tarpana and Kudapaga. Tarpana, Tripto, Priyananamidi, Tarpana. This Tarpana is indicated mainly when the eyes are Stabdha, Shushka, Ruksha, Abhikhada, and when Vada and Pitta aggravations are there, and Avilekshana. Avilekshana means visual impairment. And also it is indicated in some conditions such as Prichron Melana, Siroharsha, Sirotpada. Even it is indicated in Syanda Mantha, that Abhishyanda, Adimantha and all. But we know that Abhishyanda and Adimantha are all some Ama involvement will be there. So after relieving that Ama Lakshanas, we can go for the Tarpana. Here it is clearly mentioned that Adure Shanda Raga Ashru Shula Samrambha Dushige. That means Shantam, when the all these Ashrushula, Amalakshana, Samrambha, that foreign body sensation, everything are subsided, then only Nivade Tarpanam Yojam, Shuddhayo, Murthakayo. After purification of the body and the head, we can go for Tarpanam. And again, Durdina, Atyushna, Shiteshu. It should not be done in bad climates. And Chitta Ayasa Bhrameshuja. It can be indicated, done only in such patients which are having mentally strong. And Ashanta Upadrave cha Akshne. Ashanta Upadrava means all the Upadravas, all difficulties or all Amalakshanas, when it is not subsided, means we should not go for Tarpana. That means Tarpana is purely a Brahmana therapy after relieving all the conditions. And duration of Tarpana, that is 3 to 7 days usually. Here Acharyas have given us that for Sandhigada 300, Shuklagada 500, Krishnagada 700, Matragala, Drishtigada 800, Vadaja 1000, Pittaja 800 and Kaphaja Rogas 600. But very practically, we cannot maintain all these things. So practically we are doing as, we have divided the Tarpana into 3 types as Lekhu Tarpana, Tarpana and Maha Tarpana. Lekhu Tarpana for 10 minutes, Tarpana for 20 minutes and Maha Tarpana for 30 minutes. Like that we are doing, and quantity required for each eye is 25 ml.
Is a treatment method in which medicated water, cotton box with sterilized cotton, sterilized gauze and flour for bandage, gokarnam, black gram dough, medicine for tarpanam, and kidney tree. After covering the head area of the divan with disposable paper, ask the patient to lie down on the divan in supine position, directing the head towards the east. Position of the patient. Patient and the staff should pray pounding of ice first with a piece of sterilized cotton dipped in lukewarm water. Use separate cotton pieces. After that, clean the surrounding with cotton pieces for each eye. Sterilized cotton dipped in lukewarm water on and around the eye. Eyelashes. Ensure that the patient should be able to open the eye freely. If necessary, Ensure that the patient is able to open eyes freely. The medicine for Tarpanam is prepared by melting the ghrutam by dipping the vessel in hot water. After that, the melted ghrutam is filtered and taken in a sterilized vessel. Take the medicated ghrutam in a gokarnam and check the temperature of the ghrutam by instilling 2 drops on the dorsum of palm. After checking the temperature, pour it slowly on the inner canthus of the eye within the retaining wall from a height of 2.5 angulas. Instruct the patient to close the eyes while pouring the medicated ghrutam. Fill the portion inside the retaining wall with ghrutam so that the eyelid is completely covered with ghrutam. After pouring it completely, ask the patient to open eyes slowly. Cover the upper portion of the retaining wall with a piece of paper and ask the patient to blink the eyes repeatedly. Do not allow the ghrutam to become soft.
As the audio is it audible?
Yes, madam. Yes, madam.
Just the audio is not working properly. Just I will explain it in brief.
Okay.
For making that around the eyes, for doing tarpana, first we have to make the duff around the eyes with Yava, Masha, Pali should be made. That is not only Yava and Masha, and even Mudga, Godhuma, all Brahmana types of medicines we can use. And it should be at a height of 2 angula. And ghee should be taken, it should be liquefied before pouring it into the eyes. Not only liquefied, it should be filtered. And it can be made warm by keeping it in a water bath. Before pouring into the eyes, we have to check its temperature with that dorsum of the hand. And medicine should be filled up to that pakshmas should be, that eyelashes should be immersed in that, and ask the patient to open and close the eyes after pouring of the medicines. Here we are using, because while the ghee is over the eyes, the patient will be having some prakasha kshamata, that very irritation towards the light. So anyway, we are doing in a in a room which is having very minimum light. Then also we are keeping a paper over the eyes. And after the procedure, we can make a hole in at the end of this at the end of the eyes, Kalinika, not the Avanga Sandhi, and we can collect in a vessel. And after the Tarpana procedure also, we are giving mild fomentation with warm water around the eyes. Even in some condition, according to condition, we can give some yava with a small yava kiri pottery should be made and give fomentation around the eyes. And even Samyak Lakshana of Tarpana is that Prakasha Kshamada, Swasthya, Vishada. Vishada is clarity in vision,
and Lekhuda and Sukha Sopnavabodhatam, that is getting up early, getting up in the morning as fresh, like that. And Adi Yogas are Gurutva, and even increase of the disease, and Ashru Srava is all these are Adi Yoga Lakshanas. And next is benefits of Tarpanam. It is very, absorption is very high as drugs are lipid soluble, penetration is high irrespective of molecular size, and drug vehicle and bioavailability is highest, and significant therapeutic concentrations are achieved. Disposal, drug is retained for a prescribed period, even 10 minutes, 20 minutes and 30 minutes we are doing the procedure, and more than that it stays inside the eyes. And next is Pudapaga. Patramridhyam Pidhaya Pagaha Pudapaga. That means that medicine is covered by leaves and mud and cooked in Puda. That special preparation, due to that special preparation only, we are name it like that, Pudapaga. It is told that usually that Pudapaga is administered only after Tarpana. Just Sneha Pita Tanuriva Klanda, that ice will be after Tarpana, that ice will be very Klanda, that means very fat, ice become fatty, just like after Sneha Pana. For compensating that, Drik Baladhana Karina, for regaining the strength only, we are going for the Pudapaga. These are some of the medicaments which are used to prepare the Pudapaga: Draksha, Shatavari, Jivaka, Jivanti, and some suitable Ghrita preparation, and even Ajakshira we can use. That Kshira, usually we are using that Ajakshira only, and we need plantain leaves, Durva for tying, plantain leaves or lotus leaves we can use, and the mud which is devoid of any gravels, that sand particles and all. All the medicaments should be grinded well and make a paste. Even some mamsa preparations also we can include for preparing this paste. In classic it is mentioned as a Villomatra. Each medicament should be taken in Villomatra and grind it with proper liquid forms. Even all Jivaniya Ganas we can use. It should be covered with the plantain leaves and tied with the Durva. According to condition, not only the plantain leaves, we can use Eranda Patra, Kashmiri, even Vada. Like that, we can choose the leaves for covering it. It should be that medicine tied in the leaves should be plastered with mud. And thus became a bolus form. We have to keep this ball in a Buddha, in the fire. Suitable woods we can use, or gomaya, that dried cow dung we can use. Any types of foods also okay. Here we are using the coconut shells. Cover it properly and keep it like that for some 20 to 30 minutes. After that 20 to 30 minutes, when it becomes hot red, we can remove the things. After cool off, we can take the bolus and remove the mud. Just open the medicine. We have to squeeze it properly. Not only once, actually we have to refilter. The medicine is ready now. Now we have to filter it once again. Usually we are using, we will get some 20 to 25 ml of medicines. And just like Tarpana, we are doing the procedure for first 10 minutes. We are using the first set, half of the medicine. And after 10 minutes, remove that medicine and again pouring for another 10 minutes. Like that we are doing. And the types, Snehana, it is, Pudavaga is also of 3 types. Snehana, with Kakolyadigana, etc. Lekhana with honey, Mamsa and Bhasma of metals, and Prasadana with again milk and ghee, and even Tikta, Ropana Dravyas. Compliance, duration maximum 1 to 3 days. We are doing this one. Quantity 25 ml each eye. Disposal is absorption same as in Tarpana. Tissue contact time and bioavailability is also same as Tarpana. Not only these 7 procedures what we have mentioned here, also for the in the treatment of eye diseases, we are doing some more procedures like avagundana. Avagundana is one, we are calling it as also as Kirisveda. We can make a small bolus of just like for example tulasi, turmeric or tamarind leaves in a small pottery form and give fermentation around the eyes. And even Shirodhara, Takradhara, Kshiradhara, and many types of Kashaya dharas we can administer in eye ailments. And also Anulebana, how we are doing in the body, that Nyavara, that Shashtika Shali Pindaswara, that paste, how we are applying over the body, the same we can do around the eyes also in some degenerative conditions and ocular muscle related problems. We can apply. For that also, that Bala Kashaya will be made, powdered Nyavara Shashtika Shali will be made, and make paste and apply over the eyelids. And Netra Abhyanga. Usually Netra Abhyanga is advised always from inner to outer. And Akshi Piju, small, just like Pindi how we are doing, same cotton soaked soaked in oil we can keep over the eyes. These are some of the other than Kriya Kalpas, 7 Kriya Kalpas, we are practicing these also. And this is just we can conclude indications of Netra Kriya Kalpa. Seka in chronic and severe affections of eye. Ashchodhana is the first line. Seka and Ashchodhana, one is that Seka is Balavattaram, that's only. And Pindi and Pindi or Kavalika, it is Netra Abhishinda and even Rana. Vidalaga, inflammatory conditions, congestion, redness, irritation. So Pindi, Seka, Ashchodhana, Pindi, Vidalaga for Ama conditions, and Anjana, it is already mentioned, Pakwa Avastha of Netra, Alpa Shobha, Alpa Ashru, all those things. Nirama Avastha, only Anjana, and Tarpana also, Jihyade, Tamyada, Rukshada, Pakshma, Shobha, like that. In those conditions, Tarpana is indicated, and also Adimandha, Timira, that we have already discussed, and Podabhaga also, same indication as that of Tarpana. For after Tarpana, to increase the Drishtibala only, Tarpana is, Podabhaga is performed. It's just take home message. In general, topical administrations contraindicated in night due to that Srodhorodhata in the night time, and Ashchodhana, short tissue contact time but more absorption. Seka, reflex stimulation of nerve endings and temperature gradient induces biological changes. Anjana, tissue contact time and bioavailability more than Sekam and Ashchodhanam. Tarpana, highest therapeutic levels achieved than other Kriyakalpas. Pudapaga, same as Tarpana. Tarpana, visual acuity will be greatly enhanced if Pudapaga is advised after Tarpana. Pindi and Vidalaga therapies increase vasodilatation and drainage of toxins from the site of lesions. And here that honey is widely used as a medium for ophthalmic medication, which have Vyavai, Ashukari and Lekhugunas. Honey itself is, we can use it as a Kshaudra Anjana. Itself is an Anjana. And due to its viscosity of solutions, thereby increasing tissue contact and bioavailability is more for honey. Kriyakalpa preferred in daytime to obtain higher therapeutic concentration. Ancient medical scholars were aware of ocular barriers. That's why they have mentioned these ocular therapies. And arsenic and antimony compounds which cannot reach the target organ systemically can be taken topically. Just like in case of Anjanas, medicated ghridam, bhasmas of gold, copper, zinc, calcium, etc. along with chakshusha dravyas which are absorbed systematically are administered orally to fulfill the essential requirements of eye metabolism. And anyway, chakshurekshayam sarvagalam manushya yajna kartavyo jivide yavadicha. Nothing but our sincere effort to be done for protecting the eyes, because those who lost the vision, that day and night is the same, and that life is meaningless, earth is meaningless. So thank you. Sarve Sandhu Niramaya.
Thank you, madam, for sharing your clinical knowledge with us. Now we will start the panel discussion on today's topics. So I request all the speakers to join us. So the first question is to sir. Duration of treatment and Patya during and after the treatment.
Please repeat that question.
Duration of the treatment and patya during and post treatment.
Treatment in general or
Repetition needed for the treatment.
For what?
In
Diabetic
diabetic
retinopathy or any, in general in ophthalmology you are asking?
In diabetic neuropathy, sir.
Neuropathy. Diabetic retinopathy.
Oh, sorry, diabetic retinopathy.
Yeah, actually, see the treatment and duration that depends on the first stage. I mean, the stage which the person and the patient has arrived here. I mean, arrived at our OPD. What stage? Like we were just explaining about the first one is non-proliferative our stage. Then going towards the macular edema. Then towards the pre-proliferation, and finally ending into the proliferation, or going towards the complication aspects. And it depends on duration, like it depends on which avastha, I mean, which stage the patient has got. If suppose in a case of non-proliferative diabetic retinopathy, without any other macular complications, nothing it is there, can be managed only with the help of OPD medicine. Which I have explained here, like with the help of some kashayam, even the eye drops and all. But going towards the maculopathy, I mean the significant macular edema or cystoid macular edema, in which that cases and all, if the microns, I mean, usually commonly in OCT in central retinal thickness, we used to say it as 120 to 215 that microns it should be. But if it is exceeding 250, if it is below 300 microns, then maybe a gap of some 10 to 12 days of treatment with the Takradhara and Tarpanam, if it is possible, with if at all any other complications and all there, 12 days of treatment may be needed. And we all know that this diabetes mellitus is it's not a completely curable one. The same thing, even we should inform the patient that, or make aware the patient that this condition has to be followed up, because once the edema has come down, it doesn't mean that it will not it will be same as it is. Sometimes it may reoccur, so make sure or ensure that it should not reoccur. That's what. Case of going towards the proliferative retinopathy and all, maybe a gap of some 2 to 3 weeks continuous treatment, and again the patient may ask for about maximum of some minimum of some 1 to 1.5 years of time the patient may supposed to continue with the medications and treatments. Thank you. Hope you are understood.
Please explain.
Sir, next question. Which retinopathies can be used for diabetic retinopathy?
Which? What I saw this? Resaushadis.
Yes, sir.
usually we are using that Kashtaushadis more.
Okay, thank you, madam. Next question. How many days of Talapudichil can be done?
See, days of Talapudichil, usually it should be in a common sense. Commonly we have to say it as it should be in a all the treatment, not only the Talapudichil, but also the other treatments also. It should be in odd days, like it should not be even 1, 3, 5, 7. If suppose in a case of macular edema and all, 7 days of Talapudichil and all may be needed. But in case of proliferation, all the things, it may extend towards 9 days to 11 days, even sometimes maximum of some 41 days that can be done. if the Rogi Bala is good.
Okay, thank you, sir. Next question is to Anjali, madam. Please explain about sterilization and the needful cares to be taken while doing the procedures.
Usually there are two things that which first the staff should be taking care of. That is that staff should wear the mask and even hair cap. Staff should be cut the hair, cut the nails properly, and even nail polishes and bindyas, that it should not be used because there are chances to get mixed with the medicaments what we are using, because eye is that much such a sensitive organ. And even we are asking them to avoid using that rings, even other ornaments and all, that is thing. And before each treatment we are advising them to, even before also after procedure also, they have, that staff has to be clean the that that hand washing with all the steps they have to do, that too with soap solution, and it should be dried in a clean towel. That is for staff. And for the patient, before, I think in that video you might be seeing, before starting every procedure we have to clean the eyes using a sterilized cotton cloth, that too dipped in hot water. And while using that cotton used for one eye should not be used for the other, that separate two cotton should be used for each eye. And even after the procedure also, if needed, that cleaning should be done. And while that patient is to be laid down on the divan also, we are using disposable paper. After one procedure, that divan also, after one procedure, we are cleaning the divan also with the soap solution. And even the cotton, cora, all these things, and even the medicines which are using for the treatment, we are making it sterilized. Not only the medicines, even the vessels what we are using for the procedure, we are getting sterilized. These are the thing. And
can I just add one thing about the previous one, number of days in Talabodichil? Because I just had seen on chat here, what is the rationale behind the odd number and even number for the this one? I was just seeing that chat. See, there is nothing significant in that odd, and because when I was just telling in the last 14 days, 14 is not an odd number. See, this is the custom which we were, especially traditionally in Kerala, we were following like that. That's what the same thing which is continuing on. Suppose some of the cases, see, first day or second day, because of any of other complications, like as I was telling you, since all the diabetic people, I mean, sometimes some other complications like giddiness or any other heart related, cardiac related things may be because of any of the reasons, or if the Rogi Bala is less due to some of the complications or not. Sometimes in even number of days that also will be stopped. But generally we follow that 1, 3, 5, 7, 9, 11, then 14, then 21, like that. Not only in case of Talabodichil, but also in other treatment procedures too.
Okay, sir. Thank you. Next question is to Dr. Preeti, madam. What is retinal detachment, and which layer of retina will detach?
Retinal detachment is a complication of the diabetic retinopathy, or it may be complication of the hypertensive retinopathy also. Retinal detachment means the separation of the retinal layers. Retinal detachment is the separation of the retinal layers, that are the first layer, that is retinal pigment epithelium, and separation of the 9 layers, that is the neurosensory layer of the 9 layers of the retina. That are the second one is the photoreceptor layer up to the internal limiting membrane. There is a separation between the retinal pigment epithelium to the neurosensory layer. The separation between the retinal pigment epithelium in between the 9 neurosensory layer. This is the retinal detachment. This is the complication of the diabetic retinopathy also. Thank you.
Next question is to Dr. Anjali Madam. Composition of Kartavat labor.
Is there in Sahasra Yogam?
Okay, madam. Thank you, madam.
Not only.
Next question is.
Actually, that Kartavata is not only in a eye condition we are using. It can be used in the small lumps. In Shodha, in all types of Shodha, we can use the Kartavata. Even that cervical or knee or any type of edema, along with the Jadamayadi Churna or Rasnadi Churna, we are using that. That main ingredient is Sarjarasa, that and Chanjalya, that resins type of medicines it is. Chanjalyam in the Malayalam, this is the Malayalam word. So it is the main ingredient. It's there in Sastra Yoga.
Okay, thank you, madam. Next question to you only, madam. Can we adopt Tarpana in OPD case?
Adopt Tarpana in OPD case.
Repeat that question, sir. Can you adopt Tarpana in PDR or OPD? What?
OPDs.
OPD.
Sir.
We can do Tarpana in OPD, but we have to educate the patient correctly, because already we have mentioned there are that in the Tarpana we have to take care. The patient should not watch bright objects, should not be exposed to more light, should not be exposed to wind, more heat, like that. So, and one more thing that I have not mentioned here, after every Tarpana, we advise the patient to tie. As a Paschat Karma, usually we tie the eyes with some white flowers, just like Malati, Mallika, and here in Kerala we are widely using Nandyar Vatta, any white color flowers. So, if the patient is able to do all those things at home, they can do.
Okay, thank you, madam. Next question is to sir. Is it advisable to give Takradara and hot Shiro Lepa in same day?
Is it Takradara and?
Takradara and hot Shiro Lepa in same day.
Same day.
Your question, actually, sir, your sound is little bit bubbling. I mean, your question is it same treatment or same day it can be done or not?
On the same day, we can do Takradara and hot Shirodara Lepa.
Can be. It depends on Rogi Bala again. Usually, see the Murtha Tailas, once it has started, then once that one Murtha Taila is Takradara, it is there. Again, no need of going for again Shiro Lepa again. But Shiro Lepa, the forehead Lepa and all, that we do like sometimes, just for an example, I am telling you, morning hours we will be doing Takradhara, and afternoon hours that can be done, no issue. But generally it is not needed actually. It's because once one Murtha Taila which is already been done, that's it can be done, no issue for that, because sometimes some other complications may be there due to we need to understand practically. One thing we need to understand is most of the people coming for the treatment and all, sometimes first time only they will be undergoing for Ayurvedic treatment and all. So once the first day or second and all, once this towards this treatment, again some of the other symptoms like headache, all the things may be there. Again, going for Shirolabam, no issue for that. And finally, I have to say that it should be depend on the Rogi Bala.
Okay, thank you, sir. Next question is to Madam Anjali, Madam. To improve the vision, what type of Kriya Kalpa you suggest?
What type of?
Kriya Kalpa you suggest?
That Kriya Kalpa. In Dinacharya itself, we have mentioned, no? Acharyas have mentioned Anjana, Savviranjanam Nityam, Hidam Akshnoho. It should be done that Savviranjana can be used daily. But in Kerala, very practically, we are making homemade, we are using homemade Anjanas. I will explain the method of preparation of that also. Just that Sahadevi. Sahadevi is a drug. So we are taking that Sahadevi Swarasa, keep it, and take a cloth, dip it in this Sahadevi Swarasa, make it dry. And with that cloth will look like just some green color after dipping in this Sahadevi Swarasa, and dried it and make a wick with that cloth. And we can lighten a lamp using this wick and Eranda Taila. And after lighting that lamp, we will place a metal vessel above that flame, and it will get that Anjana will be collected over that vessel like that. And we can mix some ghee or castor oil over that blackish discoloration will be there. Or we can mix it with that and take it and use it as Anjana. This is very homemade Anjana. This we can use. And Acharyas have mentioned already that Tribhala is the Tribhala Sega is beneficial in all types of not only ailments, or also maintaining the eye health. So that also we can use. And age wise also, and we can select the Kriya Kalpas, and also our occupation wise also we can select the Kriya Kalpas. Because some software field means they have to use some lubricants like that. And even age wise means, for example, after some 40 years, we are, anyway we will get some presbyopia and all. So as a precaution, we can start some Anjanas. Like that we can select.
Okay, thank you, madam. Next question is to Dr. Preeti, madam. How we can take it as Urdhvaga Rakta Pitta with the special reference to diabetic retinopathy?
Urdhva Rakta Pitta means we are considering bleeding disorders. Urdhva Rakta Pitta is, there is the, in diabetic retinopathy what happens? Microvascular bleeding or microvascular hemorrhages are occurs. That's why we are considering Urdhva Rakta Pitta Chikitsa as for the diabetic retinopathy Chikitsa. Thank you, sir.
Thank you, madam. Next question is to sir. Is there any improvement in vision after the treatment in retinal detachment?
Improvement of vision in retinal detachment, it will be very less improvement only we can expect. Only thing is, I was just telling you, as madam has explained, the first layer and the other layers will be detached like this. I mean, it should be attached properly like this. Just for a symbolic thing, I am just showing you. It will be attached like this. If suppose it's only traction, like only one area, with little bit it has detached, that may be able to manage that. In that case and all, the vision can be improved. But clinically, here in detachment, actually we didn't go further studies in that. But visual acuity can be improved. But if it is a total detachment like this, then patient may have to be referred for surgery, I feel, because the result will be too, too delay, because as these Ayurvedic treatments are going to get some delayed effect, the patient may have to continuously use the medicines and all for maybe 3-4 years continuously. So it again measures the patience of the patient. That's what it is in my experience. But even Manjusha madam and all, from Delhi, madam has got a good result in managing this detachment and all. So madam had presented that. In my experience, this is the thing.
Okay, sir. Thank you. Next question is to you only, sir. How to prevent diabetic retinopathy, and what are Ayurvedic medicines and eye drops used in diabetic retinopathy?
Prevent diabetic retinopathy.
Yes, sir.
I think the diabetes mellitus is the first thing in preventing the diabetic retinopathy. As I was explaining here, like Pramehakara Chikitsa, because the non-proliferative diabetic retinopathy is the first stage of diabetic retinopathy. Again, that has been classified in like mild, moderate, severe under. The severe non-proliferative thing again going towards the proliferation under. So once the mild non-proliferative thing has diagnosed, there comes the importance of Pramehakara Chikitsa, and other complications also has to be treated well. Controlling the diabetes is the first line of prevention in going towards the further thing. And again, in treatment also, in different stages of diabetic retinopathy, once it has affected, the primary objective or the intention of the treatment is the percentage of vision which is there for the patients, that should be prevented first. Then that can be improved. Same time, the control of diabetes mellitus or the glucose level, that has got a major significant role in this preventing this thing.
Okay, thank you, sir. I thank all the speakers for attending the panel discussion, and thank you all for sharing your knowledge with us.
So once again, thank you all the organizers for including we people in this knowledge sharing session. Myself and Dr. Anjali, my wife from Sridharyam, we thank all of you, especially Dr. Seetal Sadalagi, and the sir was discussing in the panel discussion, sir was there. We thank all of you and the previous speakers, Dr. Preeti and Dr. Sudhi, all of you. Big namaskar. Loka samasta sukhino bhavantu.
Thank you, sir. We are at the end of today's webinar. So I would like to call Dr. Shivaprasad Osmani sir for vote of thanks.
Good evening, one and all. It is my honor and privilege to express my sincere and heartfelt thanks to our today's chief guest, Vaidya Jayant Dev Pujari sir, Chairperson, Board of Governor, CCIM, New Delhi, for keynote address. I would like to thank our patrons of this seminar and management team of our college, Shri DC Patil sir, Chairman, Gramin Ayurvedic Medical College, Terda, Dr. JB Algur sir, Secretary, Gramin Ayurvedic Medical College, Terda, and Shri Nilesh Desai sir, Treasurer, GAMC, Terda, for attending this function in their busy schedule. Next, I would like to thank our beloved Principal sir and President of this webinar, GAMC, Terda, Dr. L.M. Biradar sir for giving an opportunity to conduct this webinar. I would like to thank our organizing secretary of this webinar, Dr. Pankaj Patil sir, Associate Professor, Department of Shalaka Tantra, Gramin Ayurvedic Medical College, Teta. Now, I would like to thank all guest speakers of this webinar. Firstly, Dr. Shruti Givari Madam, Dr. Preeti Patil Madam, Dr. Shrikant P. Namutri Sir, Dr. Anjali Shrikant Ma'am, Dr. Satish Hadimani Sir, Dr. Shantala Priya Darshini Ma'am, Dr. Murlidhar Badger Sir, Dr. Shamsha Fayaz Ma'am, Dr. K.S. Sangoli Sir for attending the inaugural function. It is my honor to thank our teaching staff, non-teaching staff, hospital staff, and students of Gramin Ayurvedic Medical College, Tierda. I would like to thank all media personnel, registered practitioners, participants, faculty members, practitioners, undergraduate students, postgraduate scholars of different colleges across the country. Thank you, one and all. And tomorrow's session will start at Tomorrow's session will start at 2 p.m. and topics are: first session, clinical diagnosis of refractive error by Dr. Satish Hadimani sir, and second topic, management of refractive errors through Ayurveda by Dr. Shantala Priyadarshini Madam. So stay tuned and connect with us by Zoom app, YouTube Live and Facebook. Thank you one and all.